Hello. Connect. Check what? Hello. Everything? Hello. Hello. Check test. Hello. Hello. Check what? हेलो आ रहा है ना? मेरे को उसका वीडियो भेजना क्योंकि हमारे इसमें वेटिंग दिखा रहा है वो। उसका स्क्रीन रिकॉर्डर चालू कर दे, वो मेरे को भेज दे। चेक। हेलो। 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 हेलो चेक टेस्ट। हेलो। हेलो। हेलो चेक हेलो। हेलो। हेलो चेक टेस्ट। हेलो। हेलो चेक। हेलो। हेलो चेक वन। हेलो। हेलो। चेक। हेलो। 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 हेलो।
या कुन्देन्दु
हे मोठंवालं नाही का रे? हा अबे मी समजा असं आहे तर मला असं वाटते माईक माझ्या जवळ आला पाहिजे. अबे ते माईकला माहित आहे, तुला माहित आहे, पण त्या माणसाला नाही माहित ना का त्याला इकडून बोलायचं आहे म्हणून. तो माणूस काय करते, हा असा करते, त्याला थोडी माहित आहे हा माईक खिचते म्हणून. त्याला सेंटर पॉइंट पोडियम दूसरा है क्या? अरे इधर होगा ना पोडियम एखादा, ऐसा ही है. अबे था ना और एक था ना पोडियम, देखना कहीं होगा तो. हे ठेव रे इथे एक. हॅलो हॅलो. आता इकडनं बोलल्यावर येतं आवाज, पण त्या माणसाने इकडे येऊ नये आता. आप भेज टेबल भी भेजे. अरे टेबल, एक टेबल कंपनी के लिए.
Stay with me if you want it. Stay with me if you want it. Stay with me if you want it. Stay with me if you want it.
हेलो हेलो चेक A very good morning, all of you. वसंताची पहाट घेऊन आली नवचैतन्याचा गोडवा, सुख समृद्धीची गुढी उभारू आला चैत्राचा पाडवा, आला चैत्राचा पाडवा. On behalf of the Nephrology Society, I welcome you all and wish you a very happy Gudi Padwa and a happy New Year. Our region, our city is every year and in coming times seeing new horizons in the field of transplantation. So today we are fortunate to have eminent speakers and stalwarts from the field of nephrology and transplantation to deliberate and to discuss the minute and salient points of renal transplantation. And I'm sure we are going to gain a lot of experience and guidance from their guidance today. Today we are also welcoming our Honorable Prime Minister Shri Narendra Modi ji to our Orange City. And because of the VIP movements, we still are awaiting our dear colleagues. But I welcome you all to today's meeting and we'll start the proceedings. Let us begin by offering our prayers to Ma Saraswati. Dr. M. Bahadur sir, Dr. Salgia sir, Dr. V.L. Gupta sir, Monali Sahu ma'am, Dr. Jay Kriplani sir,
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या
Dr. Ukalkar sir, please come sir.
वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्या
Today we have a wide range of academic discussion and our first lecture for today is by Dr. Pradeep Salgia. Uh, Dr. Surishi Pandey is the senior nephrologist at Bokard Hospital. Madam will be joining us soon. We have an eminent panel with Dr. V.L. Gupta sir. Sir is the ex-HOD of Government Medical College and Super Specialty Hospital Department of Nephrology. Dr. Jay Kriplani, he is the consultant nephrologist at Apollo Hospital and Choitram Hospital, Indore. Dr. Manoj Dhanorkar, he is a consultant nephrologist and assistant professor at AIIMS, Nagpur. Dr. Monali Sahu, our immediate past president and consultant nephrologist at Midas Hospital, Nagpur. I welcome all the panelists on the dais. Surishi madam. Today we are very fortunate and blessed to have the presence of Dr. Pradeep Salgia, MD, FISOT ISN. Sir is a senior nephrologist and kidney transplant physician and head of nephrology at Vishesh Jupiter Hospital, Indore. He has had a very long and illustrious tenure as ex-head of nephrology, Choitaram Hospital, Indore. He has done his post-graduation in nephrology at the MGM Hospital College, Indore, and Jaslok Hospital, Mumbai, and Royal Infirmary, Manchester, UK. He was the first to introduce in Central India live-related kidney transplantation. He started the transplant program as early in 1985 and cadaver transplant in the year 2000. Until date, approximately he has done more than 1,000 kidney transplants. He has been awarded honorary fellowships in the Indian Society of Organ Transplantation, Indian Society of Nephrology, and a Dronacharya Award by the Avatar Foundation. He started the MP Kidney Foundation in 1994 for public awareness and preventive nephrology. We are fortunate to have you, sir. I'll hand over the proceedings to Surishi Pandey, madam, who is the moderator for today's session. Thank you.
Donor selection is the core of renal transplant. So I invite Dr. Pradeep Salgia sir for delivering his lecture on donor selection issues in renal transplantation.
Thank you, organizers of this program. Thank you, Dr. Surishi. आप सबको सुप्रभात और हिंदू नव वर्ष की शुभकामनाएं। आज बड़ा अच्छा संयोग है कि यहाँ पर डॉक्टर मोदी भी हैं और एक अच्छा ओकेजन भी है। आप सब एग्री करेंगे कि ट्रांसप्लांट डोनर सिलेक्शन में लिविंग डोनर और कैडावर डोनर दोनों अलग इशू है, and most important is a living donor selection. Choosing a suitable kidney donor is as difficult as choosing and as crucial as choosing a bride. आप bride ढूंढ रहे हैं अपने लिए और अपने बच्चों के लिए. A slightest mistake in selection can damage two families. So be very careful in choosing a renal transplant donor. With increasing end-stage renal disease, the need for kidney transplantation is increasing with strict selection criteria. The gap between the organ demand and organ procurement is widening. As far as the disease donor transplantation is concerned, the gap has been improved to some extent by accepting the extended criteria donation patients, and such donors have increased the supply by 50% in cadaver transplant. But what about living donor transplants? In India, almost 90% of kidney transplants are by living related donors. And here, if we follow integrated risk-based approach, we can increase the pool of donors. The fundamental principle of organ donation will always be same primum non necessary, means do no harm to the donor. There are a number of central and pivotal issues related to kidney donation. Most of you are aware of that. They are either related to the age, the time of donation, the type of surgical approach, the donor's medical condition like hypertension, diabetes, obesity, urinary abnormalities like proteinuria, hematuria, nephrolithiasis, certain inherited conditions, and immunological risks. So, who is an ideal donor? Everyone knows that an identical twin is an ideal donor. But how often we get this? A very rare occasion in lifetime to an identical twin. So the next ideal donor would be the one who has an age less than 40 years, who is related, having compatible blood group, GFR 90 plus, no medical illness, and a good urinary tract anomaly. If you follow these strict criteria, believe me, more than 50% of your donors will be rejected, and you will have again a very small pool. So here comes the integrated approach. About the donor selection criteria, most of the criteria, these are standard, and all of you are aware that includes the physical examination, especially the BMI, GFR assessment, by either of these methods, the creatinine clearance method or the radioisotope method or EGFR method. The absolute contraindications for donation are the age, less than 18, mentally incapable of making informed decisions, uncontrolled hypertension with end organ damage, and BMI more than 35, diabetics type 1 and 2, where there is a active malignancy, untreated psychiatric conditions, persistent infection, GFR less than 60, and if there is evidence of donor quotient. In all the situations, in absolute contraindications. Then there is some situation where you have relative contraindications, where the donor's age is between 18 to 21 years, creatinine clearance 2 standard deviation below the mean for the age, BMI more than 30, pre-diabetics in young donor, microalbuminuria, proteinuria, nephrolithiasis, and if there is history of thromboembolism. All these conditions have relative contraindications in kidney donation. Now, I'll cite here one of the patient of mine as an example that what one would consider. This was a patient, 55-year-old, who came to me in 1988 with a very short history, and he presented end-stage renal disease. There was a mild hypertension, and he has been receiving dialysis about 1 year earlier somewhere else. This fellow underwent a live-related transplant. Donor was his son, who was 30 years, and he fulfilled all the above criteria according to the standard. Now, this patient lived for about 10 years. At the end of 10 years, he had a creatinine of about 2.2, and he died later of acute MI. Now, about donor. The donor was relocated out of the state because of his job, and 20 years later, I learned that he had an acute sepsis and renal failure and died. The investigation of donor terminally showed that he had a small echogenic kidneys. The donor had 3 sisters who were advised to undergo a thorough checkup, but they all ignored it. Few years later, one of the sisters died of CKD. The second sister was on hemodialysis. The third sister, who was in Bangalore, finally contacted us to get an advice. So I investigated her. Genetically, I did genetic studies, and I found that she has an adult dominant tuberocystic kidney disease. Now tell me, with all this criteria, could one have found out this in the donor at that age? So now, look into all this, I would always say that donor selection is so important that you may have to go into deep history. The history may be normal, and then you may have to go to genetic study in some of these cases. So basic thing is that an unexplained end stage renal failure where you don't have any explanation, please try to consider genetic study to avoid unfavorable situations like this. So until 2010, people thought that renal donation is quite safe. There are some consensus in 2004 in Amsterdam. There also they said that it's a very fair, these are the standard guidelines. If you follow and choose a donor according to these guidelines, your donor will be like a healthy donor. But number of reports have started coming in that the donors are developing hypertension with advancing age. They are developing proteinuria. The women during their childbearing age are facing problem. So in 2013, European Renal Best Practice Guideline appeared. In 2014, the Canadian guidelines appeared. And in 2017, KDOKI came out with a guidelines for the renal donations. In 2018, British Transplant Society gave its guidelines. So there are a number of guidelines. They concurred, they agreed on a lot of points during the election, but they differed also in some of the points, which we'll come to it a little later on. But most guidelines suggested a step-by-step approach in evaluating a single parameter and then accepting to it to a accepted threshold rather than taking as a standard fixed point. Now, these are various guidelines. I'll not go too detailed into it, but these are different guidelines. And in these guidelines, I have highlighted the point where there are difference between the guidelines. So regarding donor age, we all know that young donors give the best kidneys. But at the same time, these young donors have a very high lifetime risk for developing a CKD. Donors less than 18 years, nobody accept them. Donor between 18 and 12, people accept that. And in donors who are more than 60 years of age, if you take them, their surgical risk increases. And therefore, most of the programs take the donors less than 70 years. Women in their childbearing age have a higher risk, if they are donors, they have a higher risk of preeclampsia and pregnancy-induced hypertension. So this need to be explained when you are taking a woman in childbearing age as a donor. About surgical approach, with time the laparoscopic surgical approach is taken up, and most of the guidelines now say that the donor should be subject to a laparoscopic surgery, whether full laparoscopic surgery or hand-assisted laparoscopic surgery. However, one of the Canadian guidelines says that any surgical approach is as good as this one. This is true that there is no difference in the graft outcome in between the two surgeries. The peri-operative mortality remains the same around 10 in 3 in 10,000. But the with a laparoscopic surgery, the pain and post-operative recovery is better. However, the surgical time is increased and the warm ischemia time is increased. The incidence of major complications is about 3 to 4% in most of the donor surgeries and about 10 to 18% minor surgical complications in other donor surgeries. However, with the laparoscopic surgery, this incidence has come down. Now, why the most centers have started accepting donors more than 60? Because using the laparoscopic surgery, they are having less complications. This is something which I would just throw as a question, that how many of you would accept a hypertensive donor? See, okay, fine. So somebody has said that he would accept a hypertensive donor. So there's a very standard criteria that if you have a donor who is more than 650 years, his blood pressure is well controlled with one antihypertensive drug, little strict with the KDP, that is Canadian guidelines, or with two antihypertensive drugs with the rest of the guidelines, and there is no evidence of target organ damage, his measured GFR is more than 80, urine albumin excretion is less than 30, and there's no high cardiac risk, you can take such hypertensive donors. But before that, make sure when you are assessing a hypertension, follow the standard criteria which we follow, that the blood pressure should be measured at more than 2 times in sitting position at 2 occasions. And if the blood pressure is found to be high, you may presume it could be a white coat hypertension, which is common in 20 to 25% of the population. So do ambulatory blood pressure monitoring. So this is something which the various guidelines agree that you can take hypertensives, but with these criteria. Again, for diabetics. In diabetics, we know that post-donation living with a single kidney. In a diabetics, there is a high risk of developing diabetic nephropathy. And therefore, type 1 and type 2 diabetics are excluded from diabetic donations. In our population, the type 2 diabetics, almost 50% are hidden. They are not there. So what we should do is we should try to look for pre-diabetics according to ADA criteria. And the criteria is well known to most of you, that the fasting sugar between 100 and 125, or 2 hours post 75 gram glucose sugars between 140 and 199, or HbA1c more than 5.7 to 6.4. So if you find it's a pre-diabetic patient, you may consider him as a donor, but avoid if he has a BMI more than 30, if his first degree relatives have diabetic nephropathy, or in women there is a history of gestational diabetes. Certain guidelines like European and Canadian guidelines, they exclude pre-diabetics at all. They strongly suggest don't take pre-diabetics. So this is, as I said, different guidelines differ in their approach. Like, in the clinicians also, the transplant physician differ in their approach. Some may select a patient with a different criteria, some may be in a very strict criteria. So it's an individualized approach. So it's up to you to accept which guideline. Obesity. We all know that obesity is now associated in long run with proteinuria, hypertension, and glomerulopathy. So incidence of this problem is high if you've got a single kidney. So living with in an obese patient, single kidney risks him to more complications. So if there's a BMI more than 35, then absolutely it makes a contraindication. However, BMI above 30 can be considered, but we should tell them that there will be higher risk, surgical risk, especially wound problems. But this can also be reduced with the laparoscopic surgical techniques. And whenever you're taking obese donors, usually in our live related donors, there's some gap of 2-3 months many times. So you can ask the donor to reduce their weight aggressively. Persistent microscope hematuria, whenever we have isolated hematuria, it could be urological or it could be glomerular. So if it's a urological, simply you exclude with cystoscopy, imaging, and urine cultures that there is nothing urological. If urological hematuria is excluded, then the renal biopsy should be undertaken to exclude IgA, Alports, and TBM. Now these three conditions have a very strong bearing in the future. So one should avoid patients in this situation with IgA nephropathy and Alport syndrome. I would say that some people still have point to consider these cases. Thin basement disease, which occurs in about 10 to 50% of patients with microscopic hematuria, it is considered a benign condition. However, some reports are coming up that this may in turn, because it's basically related with the call for a 3 antigen. So this may cause loss of renal function in the course of time. So cautious approach should be taken with a donor having microscopic hematuria, age less than 30. Broadly, I would say that uh, avoid donors as far as possible, age less than 30. Elderly donor, though they have a little compromise, but still elderly donors are always safer. Nephrolithiasis, see routinely when you do imaging, for a donor, you'll find that in 4% of 3% of cases they have symptomatic stone, or in 11% you'll have asymptomatic stones. So metabolic screening of all these patients should be done to find out the cause. And if they have a minor metabolic abnormality like a mild hypercalciuria or hyperuricemia, you can accept them, but avoid donors with bilateral renal stones or avoid donors with stroke, cystine stones, and primary hyperoxaluria. Donors with past and current stones with no minor disorders, they can be accepted if there is no significant metabolic abnormality. Now, use affected kidney. Whenever you have a situation like this, many times people remove, suppose 4 or 5 stone is there, people remove the stone pre-surgery and use the affected kidney always as a dictum. And here again, some guideline like a Canadian guideline says that avoid any donor with a something about connected to the stone, history, colic or something. Don't take them if it is less than 40 years of age. So in decision, very simple that nephrocalcinosis or medullary sponge kidney should be absolutely avoided. Metabolic abnormalities predisposing to stone, should avoid that. Cystine steroid, avoid the stones, and multiple bilateral stones, avoid. But a single small stone can be considered as an individual case. Now in malignancy, transplant kidney is not known to transmit the malignant cells, but theoretically it can. And therefore a proper screening for cancer should be done in all the patients. The patient who has successfully treated low-grade tumors can be considered after having a thorough discussion with the tumor board of the institution where you work. Tumors with no or minimal transmission risk, especially not in our country, but especially in the other countries, like skin cancers, non-melanoma type, can be considered for donor surgery. Now here again, I would like to say one of my patient. She was a prospective. She came to me as a prospective renal transplant recipient, 28 years old, and she was on maintenance hemodialysis for 1.5 years. She came with a prospective donor who was mother, having compatible blood group, and fitted in all the criteria as per the guidelines. There was nothing much, but when we took the detailed history of the recipient, we found that she had suffered kidney injury during her delivery. So we suspected she may be having atypical HUS and therefore subjected to a genetic study, which revealed a complement abnormality of CHR3 and CHR1 gene. There was a mutation, and in the intron also of a recessive variety. So the mother was excluded. Father was investigated, who was also having the same genetic transmission. These other siblings were also investigated. They were excluded because of the same genetic abnormality. So her husband and one of the relatives from husband's side, they were investigated as a kidney and liver donor for a simultaneous liver kidney transplant. Meantime, she was lucky to get a kidney and liver from a cadaver, and post-op almost 8 months, and she was doing very well. Now here again, where you don't have very clear-cut history in the females, that it could be atypical HUS, always think if it is pregnancy related, or in children also, think of atypical HUS if there's a history of renal failure developing with some febrile or diarrhea illnesses. And a genetic history will help you decide the right donor. In unexplained in unexplained end-stage renal disease, as I has been mentioning earlier, always look into that. I'll quote a study here that the patients with end-stage renal failure were analyzed. Amongst them, 9.3% had a monogenic cause for their renal failure. And amongst that monogenic cause, about 31 were related to PKD genes, 1 or 2, and 29 were related to COL4 genes, 3, 4, 5. The humor genes were responsible for about 3% of the cases, and rest of the 60 genes were responsible for remaining 37% of the cases. So, therefore, we should do a genetic analysis. Suppose there's a family history of PKD, and in donors less than 30 years, one should do a genetic study to find out the exact inheritance. As far as the elderly donors with a history of PKD is concerned, one can get a sufficient information from a good imaging technique. Now, regarding the immunological feature, can a kidney transplant proceed with a high DSA? Now, we all know that when we do a DSA, up to 1000 MFI value, we can take it as a negative. But whenever there is a value between 2000 to 3000 MFA, we have to take it with a caution while doing a transplant. And with a moderately high DSA, 3000, 6000, a transplant has to be carried with desensitization. And beyond that, try to avoid, and you can consider a paired kidney transplant. So this is about the higher DSI in the recipient donor combined group. Now you're taking suppose a ABO incompatible transplant. There also, if you got an anti-blood group antibody titer of up to 512, you may take it with a little caution. But any titer above 512, you will have to be very careful about the rejection process. You have to do a good desensitization. You have to follow such patient very carefully post-transplant also. This is something that when you are assessing a donor kidney, which method would you take? The heterogeneity exists between the guidelines for GFR estimation. We know that creatine clearance, when we do, it gives about 10 to 20% higher value of GFR, and a 2 standard deviation from mean can be considered for donation. Only thing with creatine collection, urine collection, creatine clearance, that during the collection there could be a patient error, which can also be checked if you measure the patient's urine creatinine. And if it fits into this criteria, you can say that the sample collection is adequate or not. The GFR, eGFR, that is equation-based estimation by MDRD CKD, they are little unreliable because they also tend to give higher values. So the best method is MGR, measured GFR by radioisotope. This is considered gold standard, and it helps in selecting between the two kidneys. Normally with other two methods, you cannot differentiate which kidney is better. We all know that there is a 10% different variation can occur. So which kidney to take? The good one to be left with the donor, the lesser one the recipient. The KDIGO guideline says that eGFR is sufficient. I mean, it boldly says that you don't have to resort to gold standard. eGFR is sufficient, and take it up to 2 standard deviation. The British transplant guideline says that it is mandatory to do a GFR estimation with an exogenous threshold, which is more logical in all this situation. Now, I like this slide very good in selecting donor. It just tells us that with age, the GFR keeps on falling. Up to the age of 40, our GFR is stable, constant. After that, the GFR is falling at a rate of about 9 mils per decade. So when you are choosing a donor, always consider his age. and according to age, you consider GFR. So anybody in a lower with a lower age, he will have a low GFR. So you can plot it according to it. And in the end, our final criteria is that his GFR should be above 37.5 for a donor, because this is the minimum criteria the patient, the donor should have in the end to have a comfortable living. The recovery of a kidney after donation, the recovery of GFR after donation, you all know, is that up to 70%. So that 70% should be at least 37.5. This is to be kept in mind. Now, survival, if it's a Japanese study, I think people will smile. It's a Japanese study where they have considered survival living donors, and there they have, it's a 38-year study where they found that here the bigger dots represent the actual survival of the donors, and below is an adjusted survival of the donors. They found that donor survival is as good as a survival of those, with comparing with those people who have not donated. And you find it's a little better also because the donors are given a good care post operative. So one should not be discouraged from donating kidney if you show them this graph. So assessing the donor, as Madam said rightly, is one of the most responsible tasks for a nephrologist. And therefore, again, in the end, I would say choosing a right donor is like choosing a right bride. Thank you.
Sir, you can join on the panel.
Can I
Yes, sir.
thank you, Dr. Pradeep, for a very excellent and lucid presentation, and the way he has encompassed and described marginal donors, which is the need of our, is, I think, is a need of the time. I just want to quote a study by Gabriel Donovich, which was published in Kidney Transplant. It's an excellent analysis he did, and that supports our hypothesis that we need to expand our spectrum of accepting the donors and move away from the ideal donor, because otherwise we can't tackle the CKD epidemic or explosion. What that study says is that suppose you imagine the relative risk of death in a waitlisted transplant patient is 1, then you fix an ideal, take an ideal donor and fix an ideal kidney, the relative risk comes down to 0.23. That means that there is a large protection against the death. But then he goes on to say that if you do a marginal donor for that point in time, now we need to define what is the spectrum of marginal donors in this patient, as Dr. Pradeep did. But if you do a marginal donor, then relative risk calculation says that the risk comes down to 0.53. So there is almost 50% protection for even for a marginal donor. So don't stick to a criteria like and say, okay, I'm very strict about selecting ideal donor. See, your purpose is to calculate the life expectancy of recipient and see whether the benefit of survival is equal to or more than life expectancy, then go ahead and do it. Now we have all kinds of softwares and indices and to calculate ideal donor from the pool of marginal donor and give them benefit.
Yes,
And
sir, your point is very well taken. Now, first question is for Salgia, sir. Sir, you mentioned about age as an important criteria in living donor selection. So, when you have a young recipient, a young patient in a family who has got multiple options of getting a kidney from a family, like a recipient of around 30 years or so who is awaiting a kidney transplant and who has options from one of his parent versus sibling. So what factors you think you will choose to select a donor for him?
I'm not sure I understood.
Looking to the studies which have been appearing now, I always feel that donor less than 60, less than 30 in a family should be avoided. The as I said, because they have a longer life to live with a end stage risk. Uh, the elder donors are always preferred. Now there may be a catch. Some people may say the elder donor kidney may have a lesser GFR, and younger donor kidney will have better GFR. But still, you will expose one person with a less chance of developing end stage disease, and therefore, I would always suggest at least select a donor between 30 to 50, so you can select elderly donors compared to the younger one.
Yes, sir. So safeguarding donors' safety for future post-donation risk of CKD is very important. So the second question is for Dr. Jay. So we always want an ideal donor or a perfect donor for our recipient. But most commonly when we sit in our clinic, there appears patients who come with family members who are very interested to donate, and they come with borderline abnormalities like mild proteinuria, urine ACR of more than 30, suppose in between 30 to 50 or 30 to 100, hypertension, microscopic hematuria, or a borderline GFR. So how do we go about them? How much we should investigate them? Should we outrightly reject them? How do you do in your practice?
So, in our setup, especially the state and the country we are living, we have to also take into account the affordability of investigating so many donors, right? And we should also look at the social background. For example, if you transplant a patient who is not able to afford medicines or so many uh, workup later in the life, so you have to select a donor which can give a good kidney without much cost and good life expectancy of both recipient as well as good kidney life to the donor. Now, everyone frequently encounters proteinuria, hematuria, stones, hypertension, just as Dr. Salgia presented. So, approach to outrightly reject this is not good. For example, if the recipient has a mother to donate and has a wife to donate, wife age 28, 30, I will naturally go for his mother first of all because of the good HLA compatibility, number one. Number two, because donor's wife age is less and she can be kept for later donation if he develops rejection or any graft dysfunction later in the life. So without, if there are abnormalities, if the patient is ready, I will definitely first of all rule out any reversible causes for the same, like stone disease, infection, malignancy, or some we frequently encounter viral fevers day in day out that can cause these abnormalities, proteinuria, microhematuria. So we can call them later, maybe 2 3 weeks later, and see if the things are persistent. We can go ahead. Secondly, if the family can agree for donation of such marginal donors, we can go for straight away kidney biopsy for the donor. And if there's not much chronicity, if everything is okay, we can go ahead with that donor. But at the same time, I will look into factor the urgency of the transplantation as well as the affordability of the patient. If the affordability is no issue, we should go ahead. But I will first prefer the older donor as compared to the young. As Dr. Salga said, the avoid donation below 30 years. We also follow the same practice. Even I do not take age less than 40 very easily. If there is an elderly donor, even above 60 to 70 years, I accept them. I keep the young donors for later. Uh, uh, if a need arises, I will give an example of the same situation which I encountered. He's a CKD patient who developed uh, ESRD somewhere around 2014, and he happens to be my driver only. He works in our factory and he drives truck. So his group is AB positive, and So he's lucky enough to have recipient any group from the family. His brother came, he was also a driver, earns 10,000 per month. Wife came, who looks after the farming and gai bhais. And mother was elderly, like 66, 64 years, with a borderline GFR of 70. So I knew the family background, so I decided that mother should donate. And his mother donated, and fortunately he's maintaining good graft function, creatinine 1.2, even post 11 years after transplantation. So not only the scientific criteria, we should also look at the social criteria while choosing a donor. I could have taken his wife's kidney, could have taken his brother's kidney, but I decided that because these are the earning members that will give him support.
Yeah.
We also supported him from monetary support. We just gave him a now guard Naukri, and we are giving him 10,000 per month from 11 years. So these are
an
so many factors.
integrated kind of
Yeah,
approach,
yeah.
looking
Not with
at
a
the
single
family
approach.
background, the
Yeah,
support and
yeah.
everything,
And
and
it is
the
always good.
marginal, even in a marginal donor, we accept.
Yeah. So if I look at my data, just a minute, if I look at my data for last 7, 8 years, 9 years, so the patients from donors from age between 60 to 70 years, they are still doing good.
Yes.
We are not seeing rejections. We are not seeing dark dysfunction. They are maintaining very good function. It is our fear of accepting a donor from age more than 60 years. But actually, if you, from the clinical experience, I would say they are very good kidneys. They do very good. And and if the donor develops CKD or mild dysfunction later on, so everyone will accept. We will also accept that okay, she is in this age, she can have kidney. But fortunately, nobody has developed any hypertension, any urinary abnormalities, or any renal failure from this. I have a good number of donation from 60 to 70 years of age, more than even 100, I would say. So I don't consider any donor as marginal. I consider so many factors before taking any donor.
Sir, in your vast practice of more than 1,000 patients, living kidney transplant patients, uh, how many pre-donation biopsies means have you ever done it?
I think 2 times. That is especially when there was a microscopic hematuria, and I was little scared of taking. Book says that TBM, thin basement membrane, is a very benign condition. You can accept this one, but the literature says that some of them may later on have a problem. So just to know that I'm not missing anything else, we've done a biopsy. And this was the only occasion, only indication where I did a biopsy.
Most of our donors, they are hypertensive, well controlled. They don't have retinopathy. There is no proteinuria, but there is an LVH which is there, only LVH. So how to go about in such patients?
Avoid any hypertensive who's got target organ damage, because it is just LVH, right? So ultimately it is involving all the vessels. So LVH means there is some degree of a arteriopathy in your kidney vessels also, renal arterioles also. So there one should avoid any donor well controlled with 1 or 2 antihypertensive drugs. But if it's got target organ damage, avoid such donors.
Thank you, sir. Now the second,
mild concentric LVH is a very
Common
regular, common
finding which is
finding on
reported.
TOTICO, which is reported.
Often.
So, do you mean to say we should exclude them?
You look for other parameters like retinopathy. You should look for a microalbuminuria also. So just they say that now you should have integrated risk-based approach. So you not on one criteria you fix up a renal donation or reject or decide. So you see what are the other criteria? For example, age. Above age 60, I mean they take donors right up to 80 also, because the chart which has been released by the British Transplant Society is very clear, very good, that even 60 years, 70 years, and if you fit according to that, you take. So similarly, it's not just the mild hypertension, you look for other things also. So then, and if there's no cardiovascular risk, you can consider.
If you have no other evidence of target organ problem, no proteinuria,
Yeah.
no retinopathy, just mild concentric LV hypertrophy, is not a contraindication. That can be accepted as a donor. If you want to be very particular, you go and study renal histopathology further to find out if there is an evidence of nephrosclerosis, but that will not come unless there is a over proteinuria and followed up by decreasing levels of proteinuria for that matter. So I am all for, you see, the decision to accept these kinds of marginal donor has to be customized and individualized. There is nothing like just reject the donor because there is a concentric hypertrophy. We are facing a problem to the tune of performing only 16,000 transplant annually in this country.
Sir, how would we go about using a donor who has diabetes or a pre-diabetes or who is detected to be diabetic on evaluation?
Fine, good. The diabetic who has, like Dr. Salgia presented the slide of diabetic and pre-diabetic where HbA1c values are in reference range. The average glucose post-glucose GTT shows good fair control of glucose, and he has ACR which is around 30. And no evidence of diabetic retinopathy or neuropathy or a nephropathy near relative of diabetes. What is the fun of not accepting this man? Yes.
Age, how important is age in type 2 diabetes to accept him as a donor, him or her as a donor?
See, the complications of diabetes are absolute. I mean, we see diabetic, type 2 diabetic, who have 15 years, 20 years history of diabetic, has no evidence of target organ damage. Against the 5 years age or 7 years duration has an overt proteinuria, retinopathy, and so it's actually the decision has to be customized and the tailored according to individualized according to the patient to patient. There cannot be a general statement like
Yes,
this.
sir. Your point is well taken. Now the question for Monali madam. How can we consider female donors with pregnancy-induced hypertension or gestational hypertension as donors?
Uh, yeah, gestational.
Female prospective donors who had history of pregnancy-induced hypertension or gestational hypertension.
Yeah, gestational hypertension per se increases likelihood of having chronic kidney disease in future. And if female is a if there is a donation done, he has a she has a more chance of having gestational hypertension in future. So it is both ways. But I think there are no guidelines which say that the history of gestational hypertension or pregnancy induced hypertension, those females should be excluded right away. But if that female, she is obese, or she has
She's
some evidence of
comorbid.
some comorbidities like long-standing
Persistent
hypertension,
proteinuria in PH.
proteinuria,
Then we
or
should
age, or evidence of some kidney disease,
not use.
then maybe
Otherwise, if the whole things I have disappeared like
she has a high chance of developing CKD. So I think we need to talk to them about
counsel the patient
counseling,
and then see if the urinary abnormalities have completely resolved, then we can probably think of accepting them as a donor.
yeah.
So the next question is for Dr. Salgia sir. Sir, with the with this advent of this enhanced immunosuppression and newer biologics, better desensitization and all, is HLA matching still important in donor selection? What are your thoughts? And
I think the overall observation which goes is that if you've got good HLMH kidney, you have a 10% 10-year survival advantage. So at the end of 10 years, you have 10% better survival with a matching. So, but in case if you don't have matched, it doesn't make, you can go ahead with the donor exception. But if you have an option to get a better matched donor, always you take it because whatever advantage you have, you should take that.
yeah, in highly sensitized recipients. So choosing a donor, either going for a paired match versus ABO incompatible transplant versus desensitizing the existing donor and using it, how would you go about it? What would you prefer in such a scenario?
In a patient who is sensitized, the antibody MFI values are very high, or in ABO incompatible if the anti-blood group antibody titer is pretty high, more than 512 or so. We should always recommend for a kidney paired exchange swap transplants. But there are bold nephrologists who have very strong belief in their own desensitization techniques. And they have been, I know them, they have been taking the donors with a high anti-blood group antibody titer or high MFIs, and they feel that they are happy with that because they don't want to wait for their patient for a paired kidney donation. So this is one thing. But always, everywhere, even the society recommends, the guidelines recommend that you should always offer them first a swap transplant.
Yeah, and amongst choosing this ABO incompatible versus desensitizing the existing donor, ABO incompatible who doesn't have HLA issues, and using a donor who is ABO compatible, but he has the recipient has DSS and all. How would you go about it?
I think ABO still would be better because ABO, if you look at the ABO antibody response, it's not a persistent, it's a early stage phase situation. But someone who is a who has got a HL antibodies, donor specific antibodies, these people tend to have a recurrence of rise in the antibody titer and they can have rejection. So still the ABO antibody, the blood group would be better.
Yeah.
Incompatible would be better.
So HLA is important in highly sensitized patients. That is what I think. And we can accept HLA mismatch in paired or swap transplants or patients who have or ABO incompatible transplants in whom we are considering. But when we expect a long life of a transplanted kidney in a young donor, the better the HLA match. If we have an option, the better we should take that better HLA matched donor. I think that is the take. So, sir has talked about genetic testing in evaluation of a donor. So, can you tell us, madam, when should we consider genetic testing? Because now this is available to us, NGS is available, they give a comprehensive risk screen for kidney diseases and all. So when should we use genetic testing to assess a kidney donor?
Genetic testing, I think 2-3 prominent indications would be presence of a kidney disease in first degree relative, which is genetic, we think. Then secondly, if a first degree relative has a disease which is of early onset or with extrarenal manifestations, features which suggest that it may be genetic. So in that again, genetic testing is required. Of if there are if there are kidney diseases in first degree relative or second degree relative, multiple second degree relatives, then again genetic testing is indicated. But I would like to know from Salgia sir what kind of testing to go for, because there is comprehensive panel or phenotype based panel, or I mean if there is a CKD-U again, I mean CKD of unknown origin or uncertain origin in the first degree relative of the donor, then again maybe the workup is required, genetic workup.
So if you have you can have a target-based studies if you suspect that it's a polycystic kidney disease or a maybe Alport something. But otherwise, if you're not very sure about it, then better to get a full genome profile, especially pertinent to renal disease. That would be a better one. And then you can ask for the subsequent if there are NCV and other values. So these, therefore, now one more indication which I was saying that the atypical HUS, when you suspect, that is a situation where you should get a genetic study because they, if you don't do it, you may end up with losing the graft very early, because many of them will require a combined transplant. Similarly, in young children, as I said again, where if there is a possibility of diarrheal or some association with renal failure, there also you should think of atypical HUS. So these are conditions. And one more thing, as I mentioned in my first patient long back, that where there is no family history of renal failure, the patient has an unexplained renal failure, you don't know what is the cause for that, then start thinking about getting a getting the genetic test for a UMOD sort of gene abnormalities. Because now it is not very expensive. It's better to do a genetic study in such patients and be safe for future.
So that study will be initially in the patient, and then subsequently, if it turns to be positive, in the prospective donor.
In the donor, yeah, that's true. I mean, it's a combined, integrated study.
So here in Nagpur, we have a deceased donor program, and we are doing not too many, but we are still doing it. So I would like to know from Dr. Jay, if you have a deceased donor, a potential deceased donor who wants to donate and he has an acute kidney injury, when you will accept and when you will think of not using that donor kidney?
See, if I'm pretty sure that he has suffered from a damage and he doesn't have any pre-existing illness like diabetes or a chronic kidney disease, and his creatinine has risen in front of me, I will definitely take it. I would not say no to the donor. But with ongoing sepsis, and if he has a disease which could have given rise to CKD also, I would say no. Okay.
So up to what severity? Means if it's a very severe kind of AKI, suppose stage 3 and all, and the creatinine is progressively rising, will you consider that as a donor, and for what category of a recipient
No,
actually?
so I will look at the urine output. If it is maintained and the
Yeah.
patient has, uh, and if I know that the creatinine has risen or AKI has developed because of the hemodynamic imbalance or possibly because of some nephrotoxic drug, I will take that kidney. It will all depend upon the severity of the AKI which has developed. As you mentioned, if the patient has become anuric, I will have a doubt. The patient is having good urine output and good other parameters, and if only the creatinine has risen or it has plateaued, then I will take it. We have taken kidneys up to creatinine even 3, 4. Above 4 we are not seen, and we are not even thought of taking it, but we have not encountered such a situation. But definitely we have taken kidney up to 3, 4 creatinine.
And in your experience, how much delayed graft function requirement? Because that is also important, because the recipient needs to be informed about that. It has got cost issues in a private hospital.
Graft dysfunction we encounter very less. It is because of the few reasons. In Indore, we are doing cadaver transplantation just like a living donor. We have a very connected system among all of us. Just like if there is a donor in the SIRS hospital, we are all connected. So once we start surgery, we prepare our recipient. So we do not face situation like carrying a kidney, and any distance is covered within less than 15 minutes. The moment we receive kidney, we usually have a bed ready with us. So we have a very good, well-connected system in Indore, and we are doing very good cadaver numbers in Indore. So we do not frequently encounter graft dysfunction except for 1 or 2 cases. We had to dialyze them for once or twice, otherwise not. If the urine output has been very good in the donor, in some patients, in some of the patients we received kidney from Bhopal, which took 4-5 hours. We did encounter graft dysfunction, only 1 or 2 dialysis, but not beyond that. So especially these patients were elderly. They have a borderline kidneys, and they had decreased urine output. So in these subset, especially oliguric patient, high creatinine and disturbed hemodynamics, in these patients we encountered graft dysfunction and need of dialysis. Otherwise, we did not encounter much graft dysfunction in these patients, and we do not consider AKI as a contraindication except for anuric. In anuric, I would definitely think for
Would you
not
go
taking the
for
kidney.
a pre-implantation kidney biopsy in such patients to decide?
It will depend upon how the kidney behaves on table. If I see if the kidney is not good on the table, I will take the graft biopsy at the same time on table biopsy.
Sir, as you are doing cadaver transplants also there, deceased donor transplants in Indore. So what is the average cold ischemia time, warm ischemia time? And in your experience, how this impacts the standard criteria donors, extended criteria donors? And have you done any DCD there in Indore?
In fact, as I said, that our intention is always to increase the donor pool, and we have been always looking to do DCD. We could not do because we didn't have that opportunity. The regarding your question of warm plus cold ischemia time, the cold ischemia time is a variable, as Dr. Jay has said, depending, because inter-hospital in the same city, it takes much less time, because by the time the kidney is taken out, other donor is already in the table, operating table, and once they start moving, the incisions on. So, and the warm ischemia time is more or less standard. Only thing is it may increase if suppose they are taking the heart and kidney together, because these fellows jump up first and they do it, they remove their organs first, and we get a last priority. But a long ischemia time, I have only one experience in one of my transplant. We implanted, it was a kidney from a young donor, and there was no person to take the second kidney. And we convinced a lot of people. After almost 24 hours, one person agreed and we implanted, saying that it may work, it may not work. It didn't work for about 6 days. After a week, start pouring the urine. So my feeling, and after discussion with others also, I feel that a young kidney, donor kidney, cadaver, even with a long ischemia time, there are chances it will open and it will work. So you have to wait for a long time.
In our experience with a young donor, we have experience means very in 2014 when we started the program over here, we had primary non-function also. It was not only the cold ischemia time, but the donor had also suffered a cardiac arrest and he was revived. Young donor, 18 years old. The other kidney functioned well. One recipient came from out of the city. It took a long time. Then she had a primary graft dysfunction, acute cortical necrosis, and we did a graft nephrectomy. So sometimes in young donors also, if like events like cardiac arrest and all, if it happens, we need to be telling this recipient that things like that can also happen, delayed graft function, cardiac arrest after all of these things, and they might need to be on dialysis for a long period of time. This was our experience.
I think what you're talking of is, see, ideally what the people talk in West is about the KDPI, that they really grade the donor kidney. But here in our situation, our recipients are not the choosers. So they get one time chance to get a kidney. So whatever kidney comes to them, in most of situation they accept it.
So of what absolute means GFR level you will say no to the kidney in a living donor?
As I said, that if you follow that guideline of British Transplant Society, it's a age based.
Yeah, age based.
So age based,
70.
there's a good graph. They said, it's, for example, uh, donor with 80 years, I'm just citing a theoretical example, donor with 80 years will have a GFR of about 50. You should accept it, because after donation, if you calculate her GFR, it would be 70% of donation. It will be still up to the 37.5 cutoff, which they say that you should have that cutoff. So even for a donor of 80 years, up to the age of the GFR is 50, you can accept it. Look into this. So this is a theoretical discussion. But as I said, 70 years you can take. If the GFR is around 60, you can, or less than 60, still you can take it, because you have to adjust it according to the age.
I think just an addition, like cutoff for GFR, irrespective of this age-related adjustment, which is very important, I suppose, because there is age-related decline in GFR. GFR less than 60 is a cutoff for rejection. I mean, that's what is general indication. 90 plus, yes. And there is a group where we have a 61 to 89 GFR. That is a pool where you have to individualize and customize your decision, because most of these patients are probably marginal donors, and their age-related adjustment and other variables which can affect GFR and are surrogate markers. They have to be evaluated in that sense. But cutoff for GFR in general is 60, yes.
Sir, what about 59?
That's a very valid question. Now, what about 88? What about 89? That's what I said. These have to be decision. I mean, I said 60, yes, rejection. But what about 59? What about 58? I mean, one or two here, there comes. I mean, see, evidence have to be analyzed and used and practiced by clinicians' intelligence.
I think
I
the
said,
Here,
I
transplant,
mean,
the practicing transplant nephrologist is a wise person. He would
yes,
make the decision rather than the guideline.
right.
Guidelines are just the
Guidelines are for
just
general
for general understanding.
consideration and
Yeah.
understanding.
But suppose you decide 59 is okay, go ahead with it. 58
Yeah,
is okay,
fair
go ahead
enough.
with it.
Fair enough.
So this is your individual call.
See,
so
evidence have to
now,
be implemented by the intelligence and acumen and experience of a clinician who is in charge of the case. So,
now,
like his question is answered, like 59, fine, good. I mean, like, because cutoff says 60, you can be strict. You need to be lenient, and therefore, probably you didn't go and probably had a discussion on KDPI and EPTS and things like that.
sir,
But
one question for you. So we have now deceased donor program which is happening, and the allotment is according to the first come first person. We are having a NOTO score, but it is there on paper. All of the parameters of NOTO score are not filled. So the concept of giving a suitable donor for a suitable recipient, so that the longevity is more. So how do you find that concept, and do you think that some kind of policy change? We know that our program is in a very nascent stage for making a major change in the policy and all, but do you think that we can do something in our system so that better quality donors, they go to the recipients who are expected to live long, and a marginal donor goes to the recipients who are older? So do you foresee such things which we can do in our
this is a very
program?
excellent question, and we have a large waiting list of uh, recipients who are expected to receive organs through disease organ donation. You see, we tried priority listing, priority scoring and priority listing. There was some problem in implementation. There are some government directives which comes in picture. There are some other issues also. But that has to be done. The priority scoring has to be applied. Not only priority scoring, like you see KDPI and estimated post-transplant survival, these kinds of indices where
Yeah, your comments on this.
you have a scoring from 0 to 100, lower is a better. They have to be, and these scoring, these indices have mainly come into the picture because we want to utilize marginal kidneys that are there, even if this is organ donation program. But I foresee this is a part of US RDS system. They have a kidney allocation system, KAS, in which KDPI and EPTS are part of those softwares, which tell you that which particular recipient is the most beneficial or ultimate beneficiary for this kind of donation, right? But I will wait. Why I will wait for a couple of days? Because we have waited a long. I am foreseeing AI-powered software where you can feed in and the AI selects the best possible recipient for that kind of donor. That will be best and less expensive because it doesn't carry any biases. It's a large database and it will do definitely a justice. So wait for some time. It is in pipeline. We will have an AI powered software where the donor selection or recipient selection will be done by that, and it will give you a sound rationale why this is so. Thank you.
So I think we have exceeded the time which was allotted to us. And thank you all the panelists. Heartfelt thanks for sharing your expertise, coming all the way to our place here. Gupta sir, madam, thank you. Thank you all. This discussion, I hope it enriches all of us for better donor selection in our transplant programs. Thank you.
I just wanted to make a comment for Salgia sir. You showed one slide twice that selecting kidney donor is like selecting a bride. So you mean to say all grooms are good? And females don't have a say.
You
No,
have to
no, ma'am. Actually, when you're presenting, you can substitute. You can write groom.
बहुत biased हो गया निकाल दो gender bias. I'm sorry for that.
I thank Dr. Pradeep Salgia sir for his wonderful lecture, and I'm sure all of us will remember this lecture for long and the discussion that followed it. I'll request all our panelists, Dr. V.L. Gupta sir, Dr. Monali Sahu madam, Dr. Jay Kripalani, to felicitate Dr. Pradeep Salgia sir. Sir, please. I request respected Dr. Ukalkar sir to felicitate our moderator and eminent panelists for today's session. Dr. Ukalkar sir has been the guiding light of our society, and we are following the foundations laid by him. I feel nostalgic today to welcome Dr. M. Bahadur sir to our society's meeting. I remember the COVID years, early as 2019, 2020, when we were puzzled how to go about the transplantation program. And grave was the crisis that we even wondered whether we could start transplants again. At that time, we had a wonderful guidance by Dr. M. Bahadur sir. And from those moments of crisis, we are here today on this auspicious occasion. I welcome you, sir, for your lecture. The lecture will be moderated by Dr. Ashwini Kumar Khandekar, sir, who is the consultant nephrologist at King's Kimsey Hospital, Nagpur. And the eminent panelist for today's session, Dr. Piyush Kimmatkar, sir, who is the consultant nephrologist at Mediterranean Hospital. Dr. Jitesh Jeswani, who is the consultant nephrologist at Nephron Kidney Hospital. Dr. Vishal Ramteke, who is a consultant nephrologist at Max Hospital, and Dr. Amol Bhawane, who is assistant professor at AIMS Hospital, Nagpur. Our panelists will be joining us soon. It is my proud privilege to introduce Dr. M. Bahadur, sir. Dr. M. Bahadur, sir, is MBBS, MD, DNB nephrology, and actually needs no introduction to our audience today. He is the Director, Department of Nephrology and Transplantation at Jaslok Hospital and Research Center, Mumbai, and has done more than 2,000 transplants till date, and amongst the leading nephrologists doing maximum number of transplants in Western India. And he has a pioneering work in ABO-incompatible kidney transplants. among the first few nephrologists who have used everolimus in a wide range and de novo approach, has a long-term follow-up of these patients over the years. He is the principal investigator for several phase 2, phase 3 trials, and the list of his achievements is endless. I welcome you, sir, for your lecture and hand over to Dr. Ashwin Kumar Khandekar, sir.
Good morning, everyone. I'm wishing you a very happy new year. And all those who came, all those local people who dared the traffic today, welcome and welcome in time. So, customizing immunosuppression, that is the topic today. And there are so many subsets when we do kidney transplant. There are so many subsets of recipients. Someone is really very young, someone is really very old, someone is very frail, someone is not as frail even if the age is high. Someone is diabetic, someone is not diabetic, someone is a second transplant, someone is someone is sensitized, someone is against the blood group. So how do you tailor to different? Someone has viral positivity either historically or ongoing. So how do you tailor all these situations? How do you tweak the immunosuppression in these situations? And then that includes induction as well as maintenance and long-term planning. So Dr. Bahadur, with his vast experience, is the apt person to deliberate on that. Over to you, sir.
Thank you, Dr. Khandekar. It's always a pleasure to be here at Nagpur, and I never miss a situation when I have to come here. Just to go back on those two things, why I'm the thing is customization. So, how old donors which we have done? Well, the donor we have done is live related is 85 years, and that kidney did well. And how old recipient we have for a transplant? Well, he is 100 years plus. So, transplanted at 75 years, now more than 100 years. He's the best in the world, means as this. And the 85 years is the second in the world. So, customizing immunosuppression for different donors, different transplants is something which we need to do. And what we are going to do is we are going to look at the challenges. Once we look at the challenges, get to the strategies, and where lies the future. So, what changes disease outcomes? What we picked up at the medical school. Do we have a pointer, please? Pointer. Sure. So, yep, thanks. Disease outcome is what we are looking at. So, in our medical colleges, there was this PSF slide, preventive social, agent, host, and environment. That determines the disease. Each falciparum malaria can walk back home or can die in the ICU. The agent is the same, but what was the change? Possibly the host, possibly the environment, possibly the social status. So, the same applies to a transplant. Immunosuppression is just one of the so many things that are important for a disease outcome of rejection or tolerance. So, we have an allograft, which is the agent causing the disease, which is the rejection, which we need to look at. We have got the host, who is the recipient. He is not the same. The host is different each time. And then we have the environment, from where he is coming from, social, economic, and then, of course, what immunosuppression we are giving it to him. So let's look at the host. Different demography, we have talked about age, sex, race, HLA, match, mismatch, PRA, sensitized, DSA, single antigen bead, medical comorbidities, diabetes, cardiac, pulmonary status, genetic polymorphisms affecting drug metabolism, CYP3-4A, NUDT15, just a few examples, infections within and without where he lives, and pre and post-transplant. Post-transplant DSA and de novo positive. So, each recipient is different. Does that mean that we give the same immunosuppression to the same? No. And there lies the question. The agent, is it the same? The graft, is it a disease donor graft? Is it a live related one? Are we talking about elderly donor, a donor with low GFR, a pre-diabetic or a diabetic donor, hypertensive donor, IHD, delayed graft function, compatible or incompatible donor? So the agent is also different. The host is also different. And as I said, the environment, the social, economic, from where your recipient is coming is also very different. And so the immunosuppression should also be different. And what is the disease? Rejection, AHR, ACR, mixed or chronic allograft. And so when we come to the immunosuppression, how do we go about it? The history. We started with irradiation in 50, and ASA came in, steroids came in, cyclosporin came in, and then TAC, MMF, aciliximab, the induction, Siro, Evero, Beletocept. And if you look at it, actually not much has come beyond maybe 1918, 20. That's where we are. And so the disease outcome are two, acute and chronic. So whenever the CNI came in, which was something like 1994, as you look at the graft outcomes, the graft outcomes which were from 1988 to 95 was here at 30 years. Then if you look at the cohort of 96 to 2005, it had bettered significantly. So the acute rejection, less than 5 years, and the chronic rejection, both improved. But from 1986 to 95, there is not much change here. There is, but not much change here also. And that is a fact. Acute rejection almost is a thing of the past. Means acute rejection is something which generally gets managed. It's no longer a problem. Chronic rejection is a must. Chronic rejection we have still not mastered, and which is what the disease outcome needs to be. And all our studies are 1 year, 3 year, 4 year, not 20 year, 30 year, 40 years. So whatever we have been reading is about acute rejections, and whatever we have to practice is for a can. So to change disease outcome, we need to check in here by early biomarkers, genetic profiling, which gene upregulates or downregulates on a pathology slide. Much before that, we actually start seeing something on the biopsies as acute rejection, and much before the clinical dysfunction kicks in. And so the main issue is the future is here, that once we do whether we are talking about the liquid biopsies, or we are talking about the biomarkers, or we are talking about the molecular genetics or the genetic profiling of the kidney biopsy to detect early changes. Because once we detect early, then we can prevent the late. Then the question really comes up, if I have to start a study today for any immunosuppressive, will I have to wait for 30 years for an end result? And so what is the surrogate marker? That's the biggest story. All our things that we have been doing, as I said, is targeting acute biopsy-proved rejection. For having a chronic allograft nephropathy, you need to practice you have to follow your study for 30 years. Then you can say this regimen was better than this. Then you would not be a nephrologist any longer. Somebody else will take it over. So what is a good marker? So when you look at the de novo DSA, that appears early and stays late. So these days, de novo DSA has become a good marker for possibly preventing chronic allograft nephropathy, which is generally humoral based, not cellular based. And as was pointed out, the iBox, which is the artificial intelligence, is now being allowed to make certain models which are being modeled for chronic allograft nephropathy, which has got FDA clearance. So these two things are real and new. So if life was simple, we would have a young, non-sensitized adult, no serious infections, no immunological challenge, well placed, affording, enthused, literate, ready for a lifelong follow-up. And we would have a donor who's young, healthy, with a good genetic match, low risk on immune workup, no comorbidities, compatible group, and a living transplant. So this is the ideal thing for the garden variety of transplants. Most of the transplants should be like this, and it's easy, and we don't really need to tailor many things to that. And so there has been some standardized setup. And what is the standardized setup of immunosuppression? From where they have come? Well, they have come from the trials. So specifically the Elite Symphony, which is the still what we practice, which actually told us that Tacro was superior to cyclosporin or sirolimus at 1 year acute rejection. But again, it achieved TAC level of 6 to 7 when it was supposed to be a low TAC study. We didn't look at the optimal MMF dose. There was no DSA, assessment, donor-specific antibodies for chronic allografts. We don't know. And it used non-depleting. Actually, it used daxilomab, which is no longer available these days, and we have changed to ATG and other things. So not necessary what came out of this would translate to what we are practicing today. And I will tell you why this is important. Then we had two steroid withdrawal studies, and each showed that it was not a good idea to withdraw actually. Whether we withdraw early or whether we withdraw late, it is not a very good idea. The Freedom study and the Estella study. And then we had the Orion study, which was a replacement study for sirolimus, and the Convert, which was a replacement study again. And both of it showed that if you replace CNI with mTOR, it's not a good enough thing, because it was thought that with the CAN is mostly due to the CNI toxicity. If we take off the CNIs, replace it with an mTOR, it's going to be a good idea. Well, it did not turn out to be so. Same thing with CSA to Evero versus continued Evero. Again, and the problem was there has been no long-term follow-up of all these studies. And most of these studies have not even quartered for a donor-specific antibodies thing. And then the latest ones, of course, has been this Evero low CNI MMF and Evero TAC Evero. And what it showed was TAC MMF steroid or Evero TAC or steroid without the MMF is almost equal. Maybe the change that we found when we looked at sirolimus at that time was nowadays we are using more of ATG than more depleting antibodies than we were doing it earlier. So now actually we have two protocols which are reasonable. 90% we are going, all of us are going on the triple immunosuppression. So standard presets are there, which is targeting multiple pathways with the reduced doses of individual drugs. And we induce either with ATG or basiliximab. And the general one is TAC MMF steroid. And this could be, in cases, changed to TAC Evero steroids. It is possible. So, but life is not that simple and straightforward, because, as has been pointed out, severely skewed supply-demand equation, and beggars can't be choosers. So we don't live in an ideal world, and we don't practice in an ideal nephrology field. So it is for these borderline real-life transplant that careful customization of immunization is required. Immunosuppression is required. It is here that we need precision medicine most in the transplant field. So planning immunosuppression. How do you do it? What do we, it is a huge field, and has to be customized to patient specific and person specific, host and the graft specific. So we look at the infection profiling of the patient, immune profiling of the patient, what is the immunization status. Based on that, we decide Obviously, if it is ABOI, whether he or she needs a preconditioning, desensitization, there are two ways of doing it. Plasmapheresis, IVIG, whether we go for no induction, basiliximab, ATG, ATLG, or Campath, or choosing maintenance immunosuppressive regimens. TAC MMF steroid, the standard one, Evero-TAC steroid, also possible now, or cyclosporin MMF steroid, or TAC MMF and no steroid, or some other combination of 2 or 4 drugs. So when, how, what to taper and replace or stop is what customization is all about. I will just give you 2 examples because this, as I say, is a topic which goes case by case. And so I've taken some few extreme cases which are not the usual. So let's look at this. 38 male had a snake bite, had a TMA, lost the kidneys. This was biopsy proven TMA. Developed CKD5 on dialysis, developed HCV, came to us for transplant. So we do about 30% of our transplants are ABOIs. So B2O, donor wife, pre-op is the usual, pre-op 200, 3-plex, ATG 50. That's our usual ABOI thing. Post-operative day 2. Obviously, we were always suspecting there could be an issue. HB drop, we had already sent for this thing earlier. It had to come back at that time. So day 2, we had schistocytes, fall of platelets, LDH high, hemoglobin down, and TAC was changed to Evero. And day 2, 4-plex biopsy showed TMA and some degree of CNI toxicity. And then the patient had loose motions and just could not accept MMF. Changed to ESA for GI symptoms. So hemat parameters improved and discharge creatinine was 1.5. Post-op 2 months, patient developed an LRTI, Klebsiella, so antibiotics, and again developed rise in creatinine. Again, a second episode of TMA on all the parameters that were there here, hemoglobin drop, LDH, platelets. And so GeneXpert also was positive, Klebsiella was positive. So again, required plasmapheresis and treatment for all these immunosuppression. And on 10 months post-transplant, 1.5, prednisolone, Evero, and ESA. 2 antimetabolites and 1 steroid, which is just not official, not done. But yet, he had a TMA first time due to a snake bite, second time due to a TAC toxicity on a transplant, TMA, and third time due to a second hit by an infection. So a TMA happening due to a second hit of different categories. So of course you will ask what was the genetic. The genetic study, the whole exome sequencing was negative. So where we have got clear documented TMAs by 3 different insults, second insults, and yet whole. So then of course they say, and this has to come back, they say multiplex ligation dependent probe amplification, MPLA. So don't think I have sent for a whole exome sequencing. I have asked specifically for a TMA panel also. It turns negative. So everything with a pinch of salt. Yes, clinical science is very important. And sometimes whatever your studies might have shown, lowest, ESA, Evero, and prednisolone, and a create 1.5, returning 1 year. If he develops any second hit, he may have another problem. So that is what I meant for customization. You need to customize for your patient. This is a recent patient, actually just discharged 2 days back. It's a standard, 45 male, CGN not biopsied, LDKD compatible transplant, donor mother 68. Donors in our place are 60 plus only, because that is how the world has come to. And I said beggars can't be choosers. And so, yes, so generally we have donors between more than 50% would be spouses, and most of them would be 60 plus, and most of them will be diabetics recipients. GFR, you look at this 33 ml, that's 33 ml donor GFR. And here I would definitely want to point out, please do, well, I would definitely suggest only EGFR for a donor assessment is not okay, 24 hours is not okay. That plus DTPA scan is a must, because it is not infrequent to find a 60-40 distribution or 70-30 distribution wherein the overall GFR is very good, but when you look at it, your GFRs are completely skewed. So what we do is, even if you have a total GFR of 65, 70, if I am able to keep 35 ml, so that was from the last lecture, if I am able to keep 35 ml to the donor, and if it comes to 33 ml to the recipient, 30 to the recipient, 31 to the recipient, as was very ably pointed out by sir, that if you look at whether if he continues on dialysis or whether he gets such a impaired kidney as a transplant, there's a huge difference in the life quality, life quantity, and morbidity and mortality. So we do take such patients. And obviously with a very clear rider, we tell the patient कि भाई इधर 30, 31, 32 ले रहे हैं. Don't expect, because we have got a 10-bedded transplant unit. So they compare notes कि उसका तो 0.9 आ गया और मेरा तो 2 पे अटक गया. So that is very important to counsel. You see, I am not saying you come for a transplant. You have come for a transplant. Please get another donor. Obviously, nobody has a second donor. Nobody has a donor with this nuclear family. And so then you please understand कि भाई मैं दबी हुई किडनी ले रहा हूँ और ये क्रिएटिनिन मेरा 2 के आसपास रहेगा. हैविंग सेड दैट, अगर ये 2 पे रहेगा तो वो 2 पे रहने वाला है, बिकॉज इट्स नॉट अ डिजीज किडनी. दैट इज द डिफरेंस बिटवीन अ क्रिएटिनिन विच इज अ diseased kidney of 2 and a healthy kidney of 2 is a very different ball game. We have now follow-up of more than 10 to 12 years of these marginal kidneys doing excellent. For this patient also, you will just see creatinine comes to 1.5. Obviously, we target them for 2, कि तुम्हारा 2 ही रहेगा. If it comes, we are happy. If it doesn't, we have something to stand by to. So anyway, it came down to 1.66, and so it was the standard triple immunosuppression. Only thing is important was, it was coming down rather slowly for us, and the attack level is huge on the second, third day, 41. We reduced from 5.5 to 4.5. It was still 24. We reduced further, and create was coming down, so we were not very worried about, because it comes down pretty. Why it is so high initially, we'll follow up this later. And then it started going up. So it started going up. So it went up to 2 and, remained 2. Despite our, reducing the dose of TAC, and the TAC was 7, and I go for the CMI method only, and 3.5 milligram dose. So it was a Saturday, Sunday. So biopsy would also have taken some time. So we just pulsed, this looks to be ACR, because we've got the tag down, yet the things are not moving. Having said that, it did not move further. So what would we do now? So it's not, doesn't look like a rejection. TAC is quite reasonable. We have already pulsed him. Means if it is a simple ACR, it's not gross ABMR. It's not behaving like that. It's not HUS. So that's what we say, customization. So what we do, we wanted to go down these, because of course we know that even the GFR is 33. So this may be a very TAC sensitive. All these GFRs which are low are very TAC sensitive and accept very low TAC levels and very low TAC doses. And so we did a quadruple. So that is what we do. We added Evero to this so that I can get the TAC still further down. and then the patient has been discharged 2 days back within 1.5. So he at present is on an Evero with a further reduced TAC, and an MMF and prednisolone. Will I continue with all those four? No. Once I know that he's well balanced, he'll be on a 3, which is the usual one. But so that is what I say. You may go for a 2, you may go to 4. What we have read from all our studies is for guidance. And we need to take our guidance. We need to know what's happening. So it's the overall impression, overall immunosuppression. What induction you gave, we give 1 milligram per kg. Everybody says ATG 6 milligram, 3 milligram. Nobody 3 milligram. All our studies that you or I read from talk about 6 milligram induction dose. That's a huge difference between that because they have got a different population. My population with all this COX background, every third patient has had COX at sometime in or the other. We can't afford to we have 6 milligrams. So what induction, what dose, whether received plasma, how many agents immunosuppressive, 1, 2, 3, 4, how managed long time it determines the overall outcome. So we need to customize what is known as net state of desirable immunosuppression. It's not TAC, it's not steroid, it's not it is the net state of immunosuppression that we need to target to customize our immunosuppression. And therein comes the role of the precision medicine. Precision medicine in transplant. The final target is minimize toxicity, maximize efficacy, precise dosing, need to consider multiple variables and confounders, different induction agents, drug combinations, host characteristics, graft characteristics, infections pre and post transplant. So when you need to consider so many things, it is logical that artificial intelligence should help us. And there is already an iBox, this is known as an iBox. It is available. You can buy it. And so it does all of this, what sir was just mentioning. Yes, it will tell us which donor. So it has been used extensively in donor allocation now. Which donor to which person in USA. It is now iBox based. It is iBox based medical prescription is okay. Transplant medication is okay in European. It has being FDA clearance in US also. So there is also already an AI with it is a promising new tools for improving prescribing immunosuppressants with personalized dosing regimens can consider individual patient characteristics, genetic polymorphisms, and concomitant medications and diseases. Help to reduce human error in drug dosing and used to monitor and prescribe drugs. So just what is AI? So there has to be, so that we know whether we can go lock, stock and barrel with after it. So we have to understand a few things. Where are the lacunae, where are the advantages? So machine learning are algorithmic and statistical data-driven training tools. Then after there is machine learning, there is deep learning. So it is ML, DL. And then generative AI, and then language models, the large language LLMs and the GANs, image modeling and video models. So these are all the modeling of AIs. And when because all of us are going to encounter this very soon, and so we should be conversant with them. And so AI-based precision immunosuppression are supposed to do this, and the ML-based prediction of immune responses with all of this which we have mentioned is already there. It is already there. But where are the learning models? The learning models are from the West. So again, the host characteristics, the agent characteristics are Western. So can we apply it to us? The answer is no. And do we have the data? Because artificial intelligence cannot learn unless you give it something to learn upon. So high quality data is required. and that is seriously missing. And so for at least for us, for another 10-15 years, it will be human intelligence rather than artificial intelligence which is going to drive it, because these models are based on the data on which it has been trained. We'll look at one data which it has been trained how to prescribe tacrolimus. So TAC, we know why this initial levels, if you do day 2, it's very high, because it actually depends also on the erythrocyte count and the albumin. The free available TAC depends on so many other factors than just your dose. And so TAC varies, so one size does not fit all, a lot of variabilities. So it's a good idea for the AI to look at this. And these are various ways we can, if there is TAC toxicity, it's a belatacept, which is very costly, not available to us. We were part of the trial, but it's a good idea. CNI free, which works as CNI or mTOR AI, but along with the CNI. So prediction model. So first a data collection, processing, feature selection, putting in the variables. Then the cohort of the data that has been fed in is divided into two. It is the training cohort on 8 out of 10. And based on the training cohort, that is a testing cohort of 2 out of 10. So on 8 of this, it trains. How does with all these factors quartered in with this dose, what is the TAC level expected, and when you change, what is to happen? And then you do it exactly. That the other thing is test. So this is prediction, and that is what is happening on testing. And when we train and test, then they form a model, and the models are multiple. So, and at the end of the day, we find what is the best performing model, and that TAC daily dose prediction is given, that this is how you should move. If this is the TAC today, what is where you should move. And so in the models, just say for this particular thing, the XBoost, Light GBM, and a TabNet, these come right on top for the predictions. And so 80 to 85% times, it will exactly tell you, if I give this dose, this is the TAC level I will get. So that type of predictability that is there. But remember, it has been trained on a data. It will give you what it is trained on. So based on that, we can use some human intelligence on the artificial intelligence to at least derive some things. So look at the two things, ATG, basiliximab. We know basiliximab we use only for low-risk transplant generally. ATG can be used across the board. So whether the two things are equal, not, there's been so many I have attended, huge, depending on which company is sponsoring what. But after looking at this, it's wonderful actually. You look at the clearance distribution, two things. I'm just looking at that. And here, these are all the parameters that they have shown. It is very small, so it's very difficult to see. But if you look at basiliximab, the clearance and distribution are affected by these parameters. Okay. When you look at ATG, none of the parameters affected. So you can give a standard dose, what's the age, what's the food, where you are, which caste or you belong to. That's a big winner for ATG to my mind. So similarly, on tacrolimus, so there are very big, clearance, absorption, distribution. What affects this? So basically, as practicing nephrologists, we are actually processing in our mind most of these features. Obviously, it becomes easier for a machine to do it, but that's where it is coming to. So TAC, MPA, look at MPA, how many things change the clearance, distribution, protein binding, absorption, enterohepatic circulation, and metabolic pharmacokinetics. We only focus on if there is कि भाई lose motion हो रहा है तो पक्का TAC बढ़ेगा और बढ़ता है. So, but that is only just one of those things. There are so many other things on which MPA level will actually vary. So there are some promising drugs on the anvil. I just thought I'll just carry with you. So we have, as I say, most of the activity has moved to the B cell from the T cell. So the T helper cell, naive B cell, memory B cell, plasma cell, regulatory T cell, endothelial cell. And so what are the new drugs that we have? So we already have the CD20 Ritux. So we have obinutuzumab. All these are, most of them I can tell you. I'll tell you which ones are already in phase 3 trials. So we are likely to get them. Belatacept is with us, but then CD40 ligand is also in advanced trials. Belimumab, we we were tocilizumab. We had a good round with COVID, so not the best. Bortezomib. Uh, if you look at this, daratumab is being used, is already in phase 3 trials for acute humoral rejection and doing very well. So this is likely to come out. CD38 monoclonal antibodies. And this IDS apheresis, and I'll get down to a, I'll tell you about IDAS because this actually lyses the HLA antibodies per se. So this is apheresis. There is one drug antibody to this which is very good and gets the anti-HLA antibodies for desensitization. It is supposed to be very good. So we'll come to that. And of course, then the endothelial cells, we have the complement bindings. So we already have the eculizumab, which works very well. If you have had a bad acute humoral rejection, eculizumab, except for the cost and the availability, does wonders. It just, we have got 5 patients. It just takes care of this whole thing. So there is anti-CD5, anti-CD3. 3 days back, FDA has given a clearance, not for a transplant, but for something else. And C1 INH also this. So there are antibodies to complement the terminal phase of complement activation. So this specifically, this is phase 3 trial, IDS, imlifidase. It cleaves the IgG, quickly reduces anti-HLA antibodies. It's a good desensitization strategy and for ABMR treatment, but it can develop antibodies. And so maintenance agent, I will not go into that. These are all the new ones that are available. And I think I should stop with this. So if you have more questions than answers after the talk, then it was exactly this which was desired, to explore, improve what the future is going to be about. Thank you very much.
Yes, we do have lots of questions in mind, and hopefully we'll bring them to the panel. I request you to please join the panel. Let's uh, Now that we have heard about the various options and various drug options, various scenarios, let us discuss specific scenarios and let us look at from a different vantage point. For example, I would like to throw the first question to Dr. Bahadur itself. Is now Transplant without an induction is almost becoming a rarity. So, what are the situations where you would say, I don't want to give any induction at all?
Yeah, so a low risk transplant, non-affording, first things, very important, not affording, low risk, patient having pre-existing illnesses, such as treated tuberculosis, a bad lung. We do everything. So if we already have some infection focus which is there, father is giving the kidney to the child, DSA is negative, and matching is good. Besides that, good graft is getting a 40 plus GFR graft. Immunologically, as we say, absolutely okay. And there is some problem which can happen, means infections. Plus, he is also not affording. He is the ideal candidate for no induction. Have we done it? The answer is yes. And sometimes, if there is a referral wherein uh, it's coming from, they don't allow for induction. And if you have this patient, he's the right patient.
Wouldn't you worry about, for example, there's a history of almost all patients who,
No,
before
no.
reaching us,
Low risk, that's why low risk means no sensitization. No sensitization, no blood transfusions. That's what I'm trying to say. No sensitization.
so just extending that question to maintenance, Dr. Piyush, when would you go down on the maintenance immunosuppression? For example, from 3 drug to 2 drug. Dr. Bahadur did mention certain scenarios and he did discuss that reduction in maintenance immunosuppression. What would you recommend when are those scenarios compelling enough to go down in maintenance?
So, in our scenarios, the cytopenias, immunosuppressed states, um, a low GI tolerance, possibly these could be the things which could bring down possibly the antimetabolites, because tacrolimus CNIs would be the backbone of our maintenance immunosuppression. So usually these would be the scenarios, I think.
Would you reduce that after a malignancy, for example? Jitesh or Piyush?
Uh, After malignancy, yes, if it is a aggressive malignancy, anti-metabolites, we know that they are not recommended. So better to stop the MMF. TAC also can lead to, but then I think it's always a case-based approach. How aggressive is the malignancy? And of course, life-saving is more than a graft-saving. You may consider mTOR inhibitors. We know they have anti-tumor properties as well. So mTOR inhibitors are a better option to modify your regime probably.
And BK virus is something which is very common. It's happening very commonly these days, and that is one of the major reasons why we are off an antimetabolite. And second is malignancy. Very correctly pointed out. A lot of malignancies. All those who are following up on a long-term transplants, 10 years, 12 years, 20 years, 30 years, we're seeing huge amount of malignancies. And so it is not a good idea to just city all, city all, city all. Yes, if you are if this particular patient looks tolerant, please see if we can, and the patient is regular in his follow up. These two things are very important. Then otherwise the delayed consequences of immunosuppression starts kicking in, and they are real. That's what I'm saying. This malignancy is a real issue. BK virus in the initial stage is a real issue.
Yeah, I guess we start spotting malignancy as your practice grows older and denser and richer. So you did mention tolerance, Dr. Bahadur, in your talk. Um, are we any closer to achieving tolerance in immunosuppression? And wouldn't that be the ultimate tailoring of immunosuppression?
And that is true, but I think xenotransplant will catch up earlier than this. To my mind, xenotransplant. So now we already have these two patients who are continuing, and that is very encouraging. We were in a conference in the ASN. There are three groups who are working on xenotransplant. See, tolerance, of course, the people are working on it. I don't know, not, uh, but that also more based on the cell-based therapies rather than what we were working at. That is where tolerance is going. But xenotransplant looks to be moving. Looks to be moving. Yeah.
And just stretching that reduction in immunosuppression a bit more, um, what is your, and this is to the whole panel, and maybe we can start with Dr. Amol. What are your opinions on steroid withdrawal, early, late, and maybe Dr. Bahadur can share his experience on that.
Just now, sir already elaborated it on steroid-free protocols. Actually, in our setting, to say it's completely steroid-free, I don't think it is possible right now. Because there are studies which already shows if you do early steroid withdrawal, there is more chances of rejection. So we like or not, we have to depend on steroid.
And so I like to add on this. Have we done steroid free? Yes, we have done steroid free. Are there certain patients steroid free? There are patients steroid free. The thing is, if you want to do steroid free, to which patients would you offer steroid free? That is the first question. So the thing is pediatric, young girls. Well, I am very clear about it, teenager and less, wherein this patient has to go for life. Young girl doesn't want to get disfigured also, and a lot of things to go. Second, those patients with multiple, suppose RTAs, young patients with already a huge number of defects, bow legs and all that. So for these patients, definitely we have done. But then the regimen is different. And then it is a regular 6 milligram per kg ATG and an early steroid withdrawal. So this thing doesn't work. You can't withdraw at 1 year, 2 year, 4 year, 5 year. That is a little dicey. We can only reduce it. From 5 it can come to 2.5. But no steroid is not a good idea. But if you want to do a steroid free, it has to be the first week itself. So the first week itself is a 6 milligram induction type of thing, maybe first or divided doses. And in 7 days, your pulse comes down and you stop within 7 days. And then you continue on two, and obviously it is TAC and MMF. And the TAC dose at least 8 mg per this thing, not 8 mg, it's 8 the level, TAC level has to be 8 and above for the period. Does it work? Yes, it does work. There are centers in US who are doing only TAC free. So we cannot say, though they don't equal to each other, but for selected cases, as I said, if there is a case, and especially pediatric transplants, because they have got another, maybe they will require 3 transplants in this whole era. So yes, there is there. But generally 98% will be steroids.
I am following a transplant recipient who did a transplant in Mumbai, who was 14 when she underwent transplant. It was a steroid-free transplant, and the way she has grown, she is 22 now. And the way she has grown is really remarkable, and she has grown almost like a normal non-transplant adult. So now, suppose this lady becomes pregnant. This question throwing to Jitesh. Suppose this lady becomes pregnant, then again a different kind of tailoring would be required. And when would you start that tailoring, and when would you go back to the normal regimen? And what would you advise for the breastfeeding?
Uh, Firstly, it should be a planned pregnancy because you want the graft function to be stable for at least a year. Another thing is that proteinuria should be less than 500. These are the prerequisites. Planning perspective, MMF must be stopped at least 6 weeks before she plans for a conception, and during that time we may switch to azathioprine, which is safe. Steroids are safe, CNIs are pretty safe, and AZA is a good combination. Always the protocol is to add an antiplatelet because these patients are prone for preeclampsia and stuff. Uh, Now, what is tricky in these patients is again the TAC level, because there is a lot of unbound tacrolimus which is not measured, which is very difficult to measure, and we are very tempted to change the TAC level, the TAC dose according to the TAC levels. So the very little cohort of patients I had, and I took help with some of the colleagues here and my guide as well, is that if the graft function is stable throughout pregnancy, and don't rely much on the TAC levels because they sometimes they come haywire. So free TAC level, unbound TAC level measurement is very difficult. That is one thing which is very tricky. Regarding coming back to the regime, I feel if the graft function is stable on your steroid, TAC, and AZA, I would probably continue the same regime. Because a lot of times patients want to do breastfeeding, and we know that the AZA is safe for breastfeeding as well. And a steroid dose of less than 20 is also not a contraindication for breastfeeding. So I would probably continue the same regime if the graft function is stable.
Again, a question to the entire panel. What is your minimum steroid dose? Is it 7.5? Is it 5? Is it zero point 0.1 milligram per kg? Is it daily, alternate day minimum? let's say 5 years have gone by, what would be your minimum dose by then? We can
Minimum
start
we
with
have used is 5 and 2.5 alternate day. That's the minimum we have used in our setup.
Yeah. So 2 months, all our patients are on 5 milligrams, and generally this 5 milligrams continues unless we need to change. And then as we go at 20, see, after 10 years, 15 years, 20 years, at 20 years they would be at 2.5 milligrams. That's how it would be. So you keep on reducing, and the reduction is once a week, because they are coming 5 days, 6 days they are taking 5 milligram, one day 2.5. Next time they come, so twice a week, thrice a week, and that is how slow. We need to reduce steroid, but at when we know that the graft function are stable, and then we do it slowly over years. So another 20-25 years, most of the patients will be on 2.5 plus this thing, and just follow those things. The steroid free thing, so steroid free. If you have to put in steroids, you can actually take off these patients. You can take off steroids, because one of these was a sickle patient, sickle transplant from a sickle mother, and developed COVID. So we had to at that time give steroid, and now he's off steroids, so he's okay. So it is possible, if he's on a steroid free, we can go back to steroid free.
But wouldn't it be better weight based? For example, someone is 100 kg. Um, would you be comfortable keeping him on 5 milligram?
पता नहीं
Again,
practice
sir, it is
practically fine.
more of a individualized
I know.
thing. During steroid, we should also take the account of the steroid toxicity. For example, someone is having steroid related
All the more
toxicity.
means if he's obese, I would
Is
like
obese, for example, he's having bone related issue about steroid, like hip related issue, vascular necrosis. So we, in that case, we make reduce.
HP axis is supposed to be less triggered after less than 7.5 mg of dose, irrespective of it. That's what
True, true. But is it weight based? That is my query. Okay, so the consensus is it should not be weight based, and probably 5 milligram is enough. Um, Another scenario is the second transplants, which is becoming more and more common. And also, what is becoming more and more common is that we are testing more and more immunologically. So now we know traditionally that second transplant we are geared up for higher immunosuppression, stronger immunosuppression. But then we are also working up immunologically, and we find that the single antigen beads and everything is not very high. So, would you still give Amol higher immunosuppression if the single antigen bead is negative, if the flow cross match is negative, if the PRAs are negative? Would you still, being a second transplant, give much higher immunosuppression?
No, sir. Actually, if the all immunological profile is negative, and if the patient's other profile is also, for example, in case of second transplant, many times the patient may have some infective issues or like that. So it is like a, I would like to continue with the standard immunosuppressions like in first transplant. So there is no reason, I think, to have increase the dose.
Would you be worried about memory response?
Yes, that is one possibility, sir. But then there is a already immunological profile. You said even single antigen is negative. So if it is like that, so it is better to monitor rather than to overtreat. Because infection in our, in case, especially in the second transplant, when it's second transplant, the infection things is more worried to the mind. Rejection is already there, but then infection takes the front seat.
So, Dr. Bahadur, do you do DSA monitoring in such patients, either in sensitized patients or second transplant patients, and how often?
No, so it will be case based, not for every patient that we are doing DSA, but to my mind, over time, I think we should be doing that. And I don't know how commonly people are doing single antigen and what is the practice here. But generally, what's the practice here?
Generally, PRA is done in everyone, flow cross match is done in everyone, and if PRA is negative, then single antigen bead is not usually done. So that is my practice, and I believe is similar
And DSA,
with most
DSA you are
others.
doing? DSA. So because what we find is DSA positive, because we were mentioning, he was mentioning based on DSA. A lot, if the thing, a person comes to be DSA positive and you do a single antigen, so many times we are surprised that single antigen bead is negative actually. So just not doing a transplant because of a very strong DSA, at least 5, 6 patients we have been easily able to do with a single bead, which is okay. He doesn't just have those antigen,
Yeah,
which
but
actually
DOS is
came.
producing.
Also, a question that never gets old is the role of protocol biopsies in tailoring the immunosuppression. What would you say, sir?
So we are not doing protocol biopsies, but indicated biopsies.
No, when there was a Spain who advocated protocol biopsy, very aggressive. It was fortunate enough watching our own sessions. Lot of interactions. The consensus decision was that unless there are compelling indications, protocol biopsies have no place for monitoring these kind of either a CNI toxicity or graft rejection. So you don't advocate that you should do it weekly, bi-weekly, tri-weekly, and those kinds of invasive protocol biopsies are not adopted. And even Spain has rejected that kind of.
So even if you find some clinical rejection, what would you do? Well, that was the things. Yeah. Sure. And yeah, I know.
Another kind of tailoring is the whole of India is basically resource limited, but then there are more resource limited situations like public hospitals, and Amol and Piyush have been overseeing the transplant programs in public hospitals. I would like to hear from them. How would you manage? I mean, forget tailoring. How would you manage immunosuppression in such resource limited situations?
We are in the lowest strata. Patients in the government sectors are always, we have dual problem. One is the socio-economic, another is the health issue. Most of our patients are malnutrition, and most of they have lumen temporary catheters by the time of transplant. Many will not have AV fistula. That luxury we don't have. And they have many CRBSI and that also. So we keep it low immunosuppression generally. Hardly we are able to give one ATG dose. Second, we'll have to think thrice, twice, ki, should we give or should we not give? That is problem. Again, we use some, for example, tacrolimus to use like fluconazole, itraconazole or dilzem to tailor down. Many of our patients with they are not affording MMF, we shift them to azathioprines. So this is how some tricks and tick we have to do it. So we'll have to face dual, I think, infection risk also and immunosuppression. Regarding inductions, ideally we try to give induction because without no induction we don't generally use. In induction also, if we want to give basilicizumab cost is around 1.6 lakhs, 70,000 one. So rather than that 1 milligram per kg ATG, we prefer 1 to 1.5 single dose ATG. So this is how we try to just, now the package is more in MJPGY, there is a 3.1 lakh package. Previously it was 1.5 lakhs. So in that it is, we have to do whole transplant in that. So sometime we have to cut short in perfusion. We'll have to our own perfusion masala and then give to. So that's type. Now it is a luxury. We are able to give it. So this is how we.
Piyush, any different?
No, sir. Previously, as he said, the MJPJ, the package was only 2.5, for which surgery was 1.5 and 1 lakh was for immunosuppression. So we have done a few of no induction protocols, as sir have discussed, in low risk setting. And for high risk setting, a bit lower dose of ATG, what other are practicing, maybe 1.5 or even 1 mg per kg also. And also change of MMF to azathioprine has worked for some of the poor patients as well. Other points are same as I discussed.
Another scenario or problem that we face is um, tailoring the dose of tacrolimus. So there are two aspects here. One is the genetics, and the second is the lab. So would you use, Dr. Bahadur, genetic testing for deciding TAC dose? That is one part. The second part is the whole TAC level conundrum and what methods to rely on, which labs, that's a logistic question, which labs to rely on, and what is your take on that?
Yeah, so on the genetics, yeah. So one of my residents have done type 3, A5, A4. It's of no significant use. So that's very clear. We sometimes find patient is requiring 10 mg per day, which is very unusual for us. And for those we order this type type 3A. So yeah, genetics not really required. Based on that, we did that study and we decided dose versus that level, and we came to a conclusion 0.5 or more. You can predict whether he's or she is having a anomaly of the genes. But so practically speaking, not for the practice. It's of no significant use. And generally, I am using the CMIA or method and sticking to Metropolis lab actually, or our own lab is our own lab, just local lab gives us the thing, and it's quite consistent. So it's a
I,
whole blood tag, but still it works well because I am coming from at least 15 years back when this the whole story came up, whether you use which method to be used. And at that time, not many labs were doing it. So the blood samples from Bombay, from three different hospitals who were doing it, Hinduja, ourselves, and something, went to at that time UK, and it came to be so. At that time, it was found that the CMIA was superior even to the free this thing. So ever since, at least I am sticking to that.
okay, that,
Even though most of the people have switched from that.
yeah.
Which methods we are using here?
CMS method usually.
We have tried all the three labs,
Ah,
and we
sorry.
have got all conflicting reports from all different labs, and it is all over the place. Basically, it is all over. There was a point in time, at least I had stopped relying on lab levels and going by the clinical situation. And one of my patients did go to Mumbai, and Dr. Kothari called me and said, "Doctor साहब इतने level कम आ रहे हैं, आप कर क्या रहे हैं?" So I said, I'm just so confused. So I think that gives the answer that we should rely on probably this particular method. So I think we have covered most of it. Dr. Bahadur, you mentioned belatacept. Do you think it is any closer to more widespread use?
Yeah, definitely. It's a we were part of the major study, so the benefit study. So we did the phase 4 trials in India, with our center, and it's an excellent drug. It's every monthly injection is there. It is CNI free. It works well. It is equivalent to a CNI free. Means both the arms were okay, the benefit, and it has got a long-term effect. They have done the DSAs for that, and they have shown it to be quite okay. And but the only thing, the cost is prohibitive, and it's not available in India. So that's the
Sir, one question. You have used eculizumab. You just
yeah,
tell
yeah.
us. So tell us more about your experience with eculizumab in ABMR.
So that's not eculizumab is excellent actually. Eculizumab, there should be no infections because if you have any infections, you are gone with an eculizumab because either the C1 to C5 membrane attack complex is there. It's effective both for your rejection and also for your infection.
Dose, sir, how much dose you use?
That time because each thing is 2.5 lakhs जो उसका था. So exactly dose uh, the dose prescribed used to come to 7.5 lakhs, but you can manage with less. That's what I'm saying. And one of the patient actually went to UK, and they could provide him. The question is not a standard dose. I'm talking about TMAs, जिसके अंदर लगता ही है on a standard basis. And in that case, we do CD50 to decide when if the CD50, it's 50% of all the complement this thing, and it decides when we can take the patient off from. The problem is when to take off the patient eculizumab. That becomes an issue. For AVMR, it works. exact dose I'll give.
Talking of the future prospects, um, you mentioned some AI-driven models. Any existing AI-driven models that are currently in use? You mentioned the tacrolimus model,
So this iBox is
AI box.
iBox. It is available actually.
And finally, the last question to entire panel is, do you see any role of biomics coming in or immunometers? There was this Shark Tank episode where somebody pitched for an immunometer. I don't remember if he got the funding, but any thoughts from the whole panel?
It would be a good idea if you could get it, but I don't think it's an easy thing. Xenometer.
So I think that covers most of the uh, thoughts that I had. Any questions from the panel, from the house?
Sir, when we think of customizing immunosuppression, suppose if the creatinine is rising creepingly, so what is your experience of using once a day tacrolimus and in ABO compatible versus ABO incompatible? Because 30% of your transplants are ABO incompatible, as you said. So do you find any difference when we taper the immunosuppression in ABO incompatible versus ABO compatible? And what is the phase in the transplant period? Like within if we are using ATG leukopenias, they become a problem. So when you are comfortable with modifying immunosuppression, because mandatorily we need to cut down on the antimetabolites with side effects of ATG going up. So
Yeah. So one thing is, do I have a different maintenance for protocol for AB compatible or so that is no. Once the kidney settles after the tolerance period is 2 to 3 weeks, and once it develops the accommodation, once the accommodation is in, then the pattern for the maintenance immunosuppression is the same. So no difference, and it works very well. And we have been doing it from 2009, so it's a 15 years follow-up, and they are doing absolutely equal to others. The only difference in the initial phases when we had more, mortalities or morbidity, when splenectomy was being used, that was 2006. But ever since rituximab came in, it is equal. So we use Ritux as reconditioning and ATG or basiliximab as induction, and then everything remains same. And we have done this 1025 more than also with the membranes, and there's also long-term follow-up on that. At least 6, 7 patients of huge ABOI incompatible, showing more than titers, and long-term follow-up, 6 to 8 years now, they are doing well. So if the patient comes to us, कि भाई कर सकते हैं, the answer is always yes. But after the titers है कि भाई 4 lakhs तेरे को, you will require another 4 lakhs for the membrane, absorption membrane. If you have an absorption membrane, actually you can safely say yes, we can do it, because subsequently they don't have an issue, because unlike the HLA antibodies which rebound, for a desensitized kidney also the follow-up and the long-term thing is not that good. The sensitized kidney being transplanted, the long-term follow-up is not as good as a non-sensitized. But ABO antibodies, that's not an issue at all actually. It is around that time only.
and about once a daily tacrolimus and
Yeah, so where I am using once a day, I am using quite a bit of once a day. I am using it when the TAC dose becomes very low. There's a practical thing. The patient, as per TAC level, he is just requiring 0.5 or 1 milligram per day. कि 0.5 BD है या 0.5 and 1 milligram alternate day. Then I feel I am more comfortable with once a day, because I know that he will take it, and it goes around the circle, because 0.5 OD and alternate day doesn't add up. Between, if you have the regular doses of tacrolimus twice a day, then I don't think it actually adds up. We were also in the Advograph trial. I've done the Advograph trial, phase 4 trial was there. And it was nothing better than, in that actually they used 1.2 milligram per kg. We are actually not using to as an induction. That was very surprising because we generally, I don't know how it happens here, but now it's less than a milligram. 0.8 also does pretty good. So, but standard dose is 1.2 milligrams per kg weight. So, Advograph trial we have done, and the Advograph they did well, but nothing, add on to the divided doses. But divided doses, if the dose is very low, then you feel more comfortable that it could be going around the clock. But if you look at the TAC levels, when you do with a single dose and that, you'll find the TAC level is a little lower than if you have used it in divided. If I have a patient who was on about 3 milligrams, 1.5 morning evening, and I change to 3 milligram of long dose, 24 hours one Advograph, and we do the TAC level, it will be a little lower than if it was a divided dose.
I think we are running out of time, but we'll take last question from Dr. Ukalkar.
One of the common themes which I found between Dr. Salgia's talk and Dr. Bahadur's talk is the understanding or revelation that there is nothing like gospel truth in medicine. What was considered as the truth 20, 30, 40 years back has been found to be falsehood now. We were taught that renal donor, if you go by the checklist and you clear the donor, then the risk of the renal donor facing any event is as much as the risk of that person traveling up to Varda by a bus. And I have in my experience, anecdotal of course, I have seen renal donors from live donation programs come to me for end stage renal disease maintenance hemodialysis. So it's not all the safe. And there are so many decision points in this that only a local data generated information would help the patient make an informed consent, give an informed consent. Otherwise, we quote, not all of us, but many of us quote figures from the US RDS. And I fail to understand how that would be relevant to a person staying in Nagpur to make an informed consent. One of the biggest solution to this would be creation of a renal registry which deals with transplant, which deals with end-stage renal disease, or also renal donation, live-related renal donation. And I believe that professional societies should now start taking seriously this need for renal registries. Thank you.
And data collection is our contentious issue. It's bone of contention. So on that note, let us wrap this up. I thank all the panelists for sharing their views and experience and making it a very enriching discussion, and to the audience as well for participating. Thank you.
Thank you, Khandekar sir. I will thank Dr. M.M. Bahadur sir to have delivered a landmark lecture. I'll request Dr. V.L. Gupta sir to felicitate Dr. M.M. Bahadur sir. And the panelists, Dr. Ashwini Kumar Khandekar sir, please join the felicitation. I'll request Dr. V.L. Gupta sir to felicitate Dr. Ashwini Kumar Khandekar sir, our moderator for today's session. Our eminent panelist, Dr. Piyush Kimutkar sir. Dr. Jitesh Deshwani sir. Dr. Amol Bhavani. Thank you, sir. I am indeed glad and rather more happy to welcome our next speaker for today's session, Dr. Pranav Kumar Jha. His tenure as Honorable Secretary of our society has been cherished by all and is going to be long remembered. To moderate this session, I welcome Dr. Amit Pasari sir. He is the Director of Saraswati Kidney Care. And the panelist for today's session, Dr. Samir Chaube sir. May I welcome you, sir. Sir is the Director of Asian KHMC Multispeciality Hospital, Nagpur. Dr. Manish Balwani sir. Sir is the Director of Saraswati Kidney Care. Dr. Pankaj Jawandia, he is the consultant nephrologist at New Era Multispeciality Hospital. Dr. Kapil Sejpal, he is the assistant professor at Savangi Meghevarda Medical College. I welcome all panelists to the dais. Dr. Amit Pasari sir. It is a glad moment for me to introduce our speaker for today, Dr. Pranav Kumar Jha. Sir is a consultant head and Department of Nephrology at Viveka Multispeciality Hospital, Nagpur. His awards and achievements are numerous, with peer-reviewed publications over more than 65, more than 16 chapters in various books. The K.N. Udupa Memorial Oration at the Indian Society of Organ Transplant Annual Conference 2017. Bansal Award Oration at the Indian Society of Nephrology Annual Conference at 2016. He has had a huge teaching experience and mentor to International Society of Nephrology and DNV Nephrology Training Program, and his special interests in renal transplantation, ABOI transplant, paired kidney transplants, transplant immunology, and CRRT. I welcome you, sir. I hand over the proceedings to Dr. Amit Pasari, sir.
We straight away go ahead with the talk.
Thank you so much for that introduction. And I would rather sit there and keep on listening to the wonderful lectures in the past 3 hours or so we had, rather than come on the stage, because this is a precarious situation condition, because I'm standing between the lunch and all of you. But nevertheless, I think there are very valid and very nice lectures, with the first one being on donor. And as Ukhalkar sir raised this important point, that unfortunately in India, living donor advocacy is almost very poor, non-existent actually. So before we accept such complex donors, we have to keep this thing in mind. And second thing is obviously about the registry, which is missing, and many donors of our are marginal donors. So for donor, definitely we have to do things. The US data and everything is the place where you have a lot of deceased donor transplant, where the donor's life is not going to matter after that. Second talk was very interesting talk about how to tailor make immunosuppression use of artificial intelligence. My talk will be more on the natural and human intelligence, and how to navigate such patients who had a history of major infection episode prior to kidney transplant. So I don't think I need to tell this, but infection is a very important cause of morbidity and mortality in the post-transplant period. And as we are encountering more and more patients with kidney disease and end-stage kidney disease who are living more, they are going to, and being on dialysis, they are going to acquire more infections, and it's going to lead to more complicated transplants. So it becomes important what thing is in our hand to make their outcome better and to modify the immunosuppression accordingly. So infection and kidney transplant is not a good saga. It's difficult to diagnose in patient. If anyone gets infection post-transplant, it can, the clinical features can overlap with other complications like rejections and all. There's a risk of flare, which can lead to sepsis, and it needs to reduce the immunosuppression, as we have been talking, which again is not without its own risk, can lead to rejection. And it's difficult to cure because you have to continue some immunosuppression. Stopping it altogether is not a very good option in most of the scenarios. And then it can lead to increased graft loss, mortality, cost, and many other issues. So if you look at the KDIGO guidelines, it very clearly states that kidney transplantation should be delayed until all the active infections have resolved, except for hepatitis C, for which we have very nice directly acting drugs now. So as we know, our immune system, it compromises of innate immunity, which is driven by the granulocytes, and the adaptive immunity, which is basically cell-mediated and humoral immunity, driven by B and T cells. And the innate one kicks within few hours, while the adaptive takes few days and is helpful after that. Now, all the immunosuppressive agents that we are using for kidney transplant acts on these, innate or cell-mediated or humoral immunity on one capacity or the other, and which ultimately leads to this myriads of infection and problems, because all of them, it obviously it restricts our fighting capability. This can lead to infection with many new bacteria, viruses, encapsulated bacteria, as well as it can very well reactivate your older infections and cause catastrophe in the post-transplant period. So what are the factors that will decide that a patient will get infection in the post-transplant period, sorry, not infection, but what are the factors we should determine the immunosuppression, how we should be giving the infected patients? So first and foremost, as the first speakers are told, that net state of immunosuppression, that is very important. Type of infection, what type of infection are we dealing with here? What is the treatment available at hand for infection? The treatment, for example, hepatitis C, you have such a wonderful treatment. So you can tailor the immunosuppression accordingly, depending upon that. What are the chances and flare of recurrence? What if the recurrence happen, how bad it can go? And not to forget, what are the other donor and the recipient characteristics, which is going to lead to the outcome. So net state of immunosuppression, what is this thing actually? It is nothing but all these things taken together. What are the immunosuppressive therapies has the patient received in the past? How was his mucocutaneous barrier integrity, catheter, line, drains, etc.? How was there any neutropenia, lymphopenia, any technical complication like infections, graft injuries, delayed graft function, underlying immune defects, the metabolic condition like diabetes, alcoholism, cirrhosis, advanced stage, and last but not the least, various infection that the patient had in the past. All these encompass what we say as net state of immunosuppression. So although there are like many infections and we can go on, discussing about that, and we don't have time for that as well. But I think these are the few infections that we should know, and how to, tailor make our immunosuppression according to that, which are the most common ones that we encounter. Hepatitis C, hepatitis B, HIV, tuberculosis, COVID-19, and others that we discussed. So let's see this case, a 50-year-old gentleman who is a male diabetic hypertensive, CKD5 on dialysis for kidney transplantation. He is detected to be HCV positive. He has been started on directly acting agent, and he has a grade 0 fibrosis. His prospective donor is wife. There is no history of sensitizing event. Cross match is negative. What will be your immunosuppressive strategy? Now you have multiple options. You have option A with no induction, tacrolimus, microphene steroid. Second is inducing with ATG with whatever low dose protocol that we are using, giving cyclosporin instead of tacrolimus. Third is ATG induction with low dose with TMS, basiliximab induction with TMS or CMS. So, I don't think any of you will be wrong if you choose multiple options. But then I would just like to see how many of you will go with the A option, no induction. So I have one hand. B option, ATG, cyclosporin, microphenotyl steroid. There are two hands. C option, ATG induction. Okay, quite a few, 3, 4. D, basiliximab induction. Okay, no one. One, so it is there. Okay, thank you. So, and there are a few still who think that maybe 2, 3 options will be good. Anyways. So hepatitis C is an important cause of morbidity and mortality in end-stage kidney disease patient. This we know it very well. The prevalence in the general population is 0.5 to 1%. But when you look at the dialysis, it is almost 10 to 40%. Few studies have quoted even up to 70, 80%. That high. And the post-transplant flare is catastrophic. We have heard and seen patients with fibrosing cholestatic hepatitis in the pre-antiviral era. and it can lead to graft failure, and we can lose the patient also. But the last line is the most important. Directly acting antiviral, it has revolutionized the treatment. So the maximum mortality even in the previous era was seen in the first 6 months, and the anti-Lyme ATG preparation was thought to increase the risk of developing liver disease, and it was shown even in the few studies. But then there were contradiction. Other studies didn't show like that. We are always worried about the risk of post-transplant diabetes in patients with hepatitis C. And should we use tacrolimus or no? Or should we give cyclosporin because the risk is less? And also because cyclosporin has been shown to have inhibit some HCV replication in few studies. But then these all questions were predominantly in that era when you didn't have directly acting antiviral. And these patients, because the treatment option only available was pegylated interferon along with ribavirin if the patient gets a complication of hepatitis C in the post-transplant period. This was a abstract. I'm sorry, I won't be giving you very large volume and fantastic data because that is lacking when you look at the transplant and the outcome in with patients with having pre-existing infection. But then whatever is there, it's there in front of you. This is just an abstract which was in American Transplant Congress looking at the hepatitis C infection and use of induction in that specifically. And the authors looked at 79 HCV positive kidney transplant from January 95 to December 2006, previous era, right? And even in that time, what they observed and concluded was there was significant positive impact on both patient and graft survival in HCV positive recipient without any increased rate of infectious complication, without any increased risk. Now, this was a fantastic paper which was published in 2008 in the Journal of Transplantation. And this is a paper which looked at US data, OPTN data, and which was from 1995 to 2004. Now, this is a large volume data, 3,700 HCV positive patients compared to 75,000 HCV negative kidney transplant. And what they found that induction, looking at this paper also, you look at the induction therapy which has been used, right? Almost 80%, 84% have received induction in this. And how was the outcome on the this particular diagram just shows how was the patient mortality or outcome. So after 2 years, the patient who had received induction had a positive outcome and their mortality was less. What they also found that mycophenolate had reduced the hazard ratio of mortality in the patient who received mycophenolate, they had a better outcome. So if you look at the guidelines by KDIGO, once again, which came out in 2018, this is the HCV guideline, and it suggests that all conventional current induction and maintenance immunosuppression can be used in HCV infected kidney transplant patients. So coming to the next hepatitis B. Now let's see this case, a 56-year-old female who is a hypertensive CKD5 on dialysis for transplant. She is detected to be HBV positive. Her copies are 300 and she has a grade 0 fibrosis. Prospective donor is sister, 6x6 mismatch though. There is no history of sensitizing event. Cross matches are negative. And what should be the immunosuppression? I mean, we have same options. I have not modified the options A, B, C, D, E. How many hands for A? One hand. How many hands for B? Yes, quite a few. C. Okay, so he is with both. But anyway, that means ATG induction, what he wants to say. Basiliximab with, D. Okay. And the last one, E. Okay, sir is there. Thank you. Okay, fine. And what about the approach to giving antiviral to this treatment, those patients? Should we start pre-transplant and continue for 1 year? Should we start pre-transplant, stop if there is serological clearance? It can rarely happen, but if there is serological clearance, should we stop it? Start pre-transplant, continue lifelong, or start post-transplant, continue lifelong? So option A, how many hands up? Option B? Option C? Option D? So I think yes, that's fantastic because that's what we should be doing. So hepatitis B, again, once again, its prevalence in general population is high, but in Dialysis population, the prevalence is lower when you compare to HCV. Nevertheless, it is definitely a nuisance. And the worst part is that HBV will persist in the body of all the patients, even if there is evidence of serological recovery. So just the presence of anti-hepatitis B antibody is not going to give you a carte blanche that you can do whatever you want and stop the antivirals. No, you have to compete it lifelong. So, and the reactivation is very well known to occur even in HBsAg negative patient if they have a history of hepatitis B. And if you look at the risk of giving immunosuppressant, it is maximum with rituximab and alemtuzumab, followed by pulse steroids. And with the low dose steroid, the risk is pretty low. And traditionally, it has been thought to have poor outcome. And initially, in fact, the antiviral were not given routinely. And that was the reason that previous studies had shown a poor outcome. But overall, solid organ transplant patient, they fare very well with this. This is a very nice story, a very nice study which was published in 2021. It is from Korea. And this was a retrospective study though from 1999 to 2018, which looked at the outcome of hepatitis B patient getting transplanted. There were 79 patients only. 17 of these developed reactivation, and the recurrence happened only in patients who were not taking lifelong therapy. So inappropriate hepatitis B treatment, irrespective of what kind of induction they used. Although the induction they majorly used in that country was basiliximab. And the maintenance immunosuppression was same like usually what we use. And if you look at the multivariate analysis, there are only two factors which were encountered for the reactivation. One was inappropriate antiviral treatment, and second was high antibody titer. So this just summarizes what we should be doing for hepatitis B. Now, the third case is, before we move in, this is about a HIV patient, a 40-year-old male, and who has a history of stable hepatitis HIV infection on ART for transplant with donor as being wife. And he has a negative cross match and immunosuppression. Now, this is a HIV patient. So, HIV patient, first of all, are you planning to give induction? That is one question. And second question is, what kind of a maintenance immunosuppression? So rather than going to all these A, B, C, D, E, induction, how many for induction here? How many for induction? Okay, 5, 6 for induction, 7, 8 maybe, 8 for induction. So I presume that others are not for induction. So HIV initially was thought to be a contraindication for kidney transplant. HIV, no transplant. That was the previous story. But slowly people realized this cannot be the case because antiviral medications became more and more effective. It became like any other chronic disease, in fact, and that we can see also now. And so whenever these patients are for transplant, they have to be on a stable ART before they go for transplant. There are criteria to be met before transplanting them, as we know. We prefer, non-protease inhibitor regime so that it goes well with the tacrolimus and CNI and doesn't interfere much. Now, about various immunosuppression, how it helps or goes against HIV, there are mycophenolate has been shown to have antiretroviral property. So has CNI actually. Sirolimus, as we know already that in patients with Kaposi sarcoma, we are using it. And in fact, in one of the NIH trials, multicentral trial, this was a retrospective finding that mTOR inhibitors can lead to reduction of HIV viral reservoir. The initial immunosuppressives used were CNI, MMF, steroids when the transplant in HIV started. But this was the, I will say, a landmark paper in HIV because this came in NEJM in 2010. There were 150 patients who underwent kidney transplantation with HIV and in the period of 2003 to 2009. And although the patient and graft survival were excellent, you look at the acute rejection rate. This came as a big surprise. The acute rejection rate was 30% at the end of 1 year, almost 40% at the end of 3 years. And the variables which were associated with high risk of acute rejection were deceased donor and cyclosporine use. So obviously cyclosporine was out from the maintenance in these cases. Now we had a lot of talk about steroid-free transplants. So we actually did steroid-free transplant when I was at Medanta. We had almost done 80 to 84 steroid-free transplant. But as sir pointed out very rightly, steroid-free transplants, you have to do it with lot of diligence. You have to see which patient to take actually. More than 50% of them will be back to steroid and have rejection. So this was the steroid-free transplant attempted in HIV patient. This paper was published in 2014. There were 13 HIV infected patients, number not as big, but it drives the point well. And with a mean follow-up of 50 months, look at the rate of acute rejection, 60%. Or I'm sorry, it was 54% and 62% were back on steroid due to the rejection or the other reason. So the authors concluded the benefit of steroid-free regime and HIV-infected kidney transplant recipients must be reconsidered because it has a very high rates of acute rejection. Now, this was the largest data, I will say, by Doris Agev's group, which was published in AJT in 2016 about immunosuppression induction and clinical outcomes in patients with HIV undergoing transplant. It was for 830 HIV transplant done from 2000 to 2014. There were three groups, no induction versus thymo versus IL-2 blockers. And induction here was the group which had the best outcome. And induction was not associated with increased risk of infections, unlike thought earlier. And the authors concluded that in light of the high risk of acute rejection in this population, induction therapy should be strongly considered. You can see the graph survival curves on the right side of the slide. Coming to the next, our favorite infection, very prevalent in India. We are number one. 35-year-old male, hypertensive, CKD5 on dialysis for kidney transplant. Prospective donor is his mother. 3/6 mismatch. Diagnosed tuberculosis, ATT since 4 months. History of 1 unit PRBC transfusion, cross-match negative, immunosuppression, A, B, C, D, or E. Induction, no induction? No induction? No induction? Okay, many. Induction, I presume others are for induction. ATG? Only one hand for ATG? Okay. When I'm saying ATG, it's a low dose ATG. Whatever, 1 milligram, 3 milligram. ATG, basiliximab induction? Okay, few hands for basiliximab induction. Fine. So, India is contributing 27% of the global TB burden. So we are like out of 4, 1 is from us. And end-stage kidney disease patients are like 6 to 25 times more likely to develop tuberculosis. And although there is fear of reactivation, but the overall outcomes have been reassuring. Now, when I say reassuring, I'm sorry you don't have a lot of data. You go and see, you try and see what happens to the patient who get transplanted with a history of tuberculosis. No, you have less data. And this becomes very important because we are the leading ones in the world in tuberculosis. Data should be coming from us. And if you look at the guidelines even outside, they always say that you treat latent tuberculosis before kidney transplant. But in India, are we doing that? No. You do that, you are going to land up with the rejection, resistance like hell. So it's not practical. So this was a single center data which we published from Medanta. It was from kidney transplantation patient with tuberculosis because this was the very question that we had in the mind. This was a single center retrospective study of kidney transplant patient on tuberculosis on ATT when they went for transplantation. It was 71 patients. We propensity matched it with 71 patients without tuberculosis. So we had equal matching and we looked at how was the outcome. Similar outcome between the two groups. No difference at all. No reactivation at the end of follow-up period of around 4 years to 5 years that we had. And what was the induction that we used? On the right side in the demographic, left side, sorry, on the demographic details, induction was used in almost 50 out of the 70 patients in each arm because it was matched. And if you look at the thymoglobulin, it was 50%, 50% was basiliximab. This was because we were initially basiliximab heavy, but later on we shifted to thymoglobulin. So that tells you about the tuberculosis part. And the last part is about the COVID. I think all of us, I don't want to get you those bad memories of COVID-19, but it's not going to go away soon. A 46-year-old male patient with diabetes, hypertension, CKD5D, prepared for transplant, wife being the donor, prospective, no match, 6/6 mismatch. Had COVID-19 2 months back, needing ventilatory support. No history of sensitizing event apart from that. Cross match is negative. So induction, no induction. The last one. No induction. No induction, how many? Okay, no induction. And ATG induction. ATG induction. Yes, I have one person who is fond of ATG induction. Basiliximab induction. Great. So COVID-19 infection, as all of us know, was caused by coronavirus, and it was a global pandemic, high mortality, high morbidity. In fact, transplant was halted for all of us for almost 3-4 months. You remember, and the lockdown started, and then we were cautiously starting the transplant, thinking about what to give, what not to give, induction देना है, नहीं देना है, क्या transplant immunosuppression देना है. So once this lockdown eased and once we started transplant, we collected data. This is a multi-center data from 8 centers throughout the India about how the experience has been, initial experience for kidney transplantation after the COVID has eased. And these were the participating centers. When you look at the pattern of use of immunosuppression, and you find that it is almost like what it was used before that. Now, this was at a time when we are not certain about the outcome also. But so this showed that we were not very different in how we are treating these patients. And the outcome was good. The graft survival, the patient survival, the acute rejection rate was good, despite many of these patients having maybe subclinical COVID or previous COVID also. Now, Dr. Kutte, he did a lot of fantastic work and publications for COVID during the COVID-19 era. And fortunately, we were also part of his endeavors. And this was the largest data, I think, throughout the world, which looked at the management strategies and outcomes in kidney transplant recovering COVID-19, which was a multi-centric data throughout India, which consisted of 23 centers and looked at 1 year. And there were 372 patients with a median follow of 241 days, all sorts of transplant that we can think of. The acute rejection rates were very well at 9%, and the graft loss was 0.26% only. There was a low risk of acute rejection with thymo. So thymo was not causing a trouble here. And if you look at the, how the immunosuppression was used, it was same, even if the patient had a history of COVID. But if you look at this ordinal scale 6 to 7, this was the most severe type of COVID patients who had a history of ventilator requirement or NIV. In that patient, they had the use of no induction was way more than the others. So although in this paper, they have concluded that it didn't make any difference and immunosuppression was same throughout, but this was the particular subset where the immunosuppression was not same, it was different. So after this, the whole talk, this is my take-home message, that outcome of kidney transplantation in patient with chronic infection has significantly improved. One, because you have more and better antivirals at hand. Second, you have come down on the use of immunosuppression in general, rather than not only in these patients. Now, the patient with pre-existing infection definitely may need tailor-made immunosuppression. You have to consider all the factors. What are the age of the patient, type of donor, HLA matching, presence of DSA, type of infection. By the DSA, I mean single antigen beat DSA, not the lysate ones. Treatment available, risk of flare, and net state of immunosuppression. And finally, it's always the balancing act. You have to use your natural intelligence and balance immunosuppression minimization and risk of acute rejection to get the best long-term graft outcome for the patient. Thank you so much for the patient hearing.
Thank you, Dr. Pranav. I would request you to join the panel as we have the panel discussion. To begin with the panel discussion, the first question I would like to ask Dr. Samir Choube sir. Choube sir is one of the pioneers of kidney transplantation in our area with a vast experience. Sir, we commonly come across HBsAg positive patients who undergo transplant, as Dr. Pranav also discussed. And we always fear that they may develop reactivation of hepatitis B post-transplantation. So what is your policy or advice? How frequently should we be monitoring HBV DNA or some other novel markers that we should be looking at?
There is always a chance of reactivation occurring post-transplant, but there are no set criteria. But whatever we have read and the papers suggest that, and also the gastroenterologist advises us to do a core antigen or a high sensitivity surface antigen 1 to 3 months after transplant. And also depends, like Pranav said, depends on the kind of treatment the patient has been given and whether he was continuing or not continuing.
And what is your general policy, sir, to continue with anti-HBV treatment for lifelong or say till the time?
I continue for lifelong.
Continue for lifelong. Thank you, sir. My next question is for Dr. Kapil. We do come across quite a few HCV positive patients who are posted for transplantation. Mainly it happens when we see a deceased donor, a patient, a recipient for deceased donor transplantation was undergoing dialysis at a peripheral center, and he turns up for getting the kidney. He has been selected for getting the kidney, and we do a routine set of investigation and find that he is HCV positive. So what is your policy, whether you advise this patient to undergo a transplantation immediately and undergoes parallelly start directly acting antiviral therapy, or you advise him to defer the transplant till the time the DAs have been given and some kind of remission has been documented?
Sir, it mainly depends on the type of the transplant. If the patient is planned for a live donor transplant, it is better to get a SCR achieved before transplant. But if the patient is registered in a cadaver list transplant and he gets a call for transplant, and even if he's on DA or diagnosed newly during that time, we can go ahead with transplant and then probably continue start DA post transplant. So the decision will mainly depend on the type of transplant. If the patient is posted for live transplant and he is not doing good on dialysis, suppose there are a lot of issues on dialysis, we can still go ahead with live transplant and probably we can continue DAS post transplant, sir.
Any particular choice of antivirals that are available in India? Because we have guideline saying some other agents, but they are not routinely available with us.
We usually prefer sofosbuvir plus velpatasvir in our center, sir.
My next question is for Dr. Manish Balwani. We commonly come across patients who are undergoing CAPD as renal replacement therapy and are now posted for transplantation. So one thing, the dilemma always is there that whether we should be taking out the catheter at the time of transplantation or we should be removing the catheter at a later date. The another issue is if a patient has developed a CAPD, say peritonitis. So how long will you like to wait till posting this patient for transplantation, considering the various agents, pathological agents?
So we usually practice to keep the CAPD catheter in situ till the graft functions. So if the catheter is not infected, so we keep it in situ, especially in case of disease donor transplants where we expect some kind of DGF. Now about infections, if the patient is suffering from fungal infection, MRSA, multi-drug resistant Klebsiella, Pseudomonas, in such cases, we prefer to withdraw to remove the catheter and wait for minimum 2 weeks in case of live transplant. And if 2 weeks have not elapsed, then we reject the patient for disease donor transplant if the number comes. For fungal, I think we should wait for minimum 4 to 6 weeks after removal of catheter, and the patient should be on the antifungal therapy. So this is the practice which we follow, and there are no major guidelines or the data available regarding same.
My next question is for Pranav sir. As you discussed regarding the ATT treatment, anti-tuberculous therapy treatment in a patient with active tuberculosis. So after this data, have you changed your practice to just give induction regime or the intensive phase therapy prior to transplantation and to continue the maintenance ATT phase after undergoing transplantation? Or you still feel it is safer or better to complete whole course of anti-tuberculous therapy and then subject this patient for transplantation, especially in live related cases when we can probably wait if the patient is doing well on maintenance hemodialysis?
So, I mean, not only after this data, actually, we are already practicing this, and I think most of us, if not all, are practicing this. That we are giving the induction phase. We go ahead with the transplant. In fact, it's the West which is not practicing, which were not practicing this at least. And I still remember when the KDGO committee had met for the framing these guidelines about transplant in tuberculosis patient. And Dr. Kher was amongst that, and we used to have this discussion, and he put the same thing forward there. The point is that's not based on any solid evidence. There is no publication regarding that. It's just their gut feeling that, and rightly so, because they have a deceased donor transplant option. The quality of dialysis is good, so the mortality may not be that high, unlike what is there in our situation when we are going to have a higher mortality. So they were going to put this in the guideline that you should be completing the ATT before going for transplant. But then it had to be modified after this suggestion, and it was made that you go ahead as per the local practices for these. So I think for us, the best practice should be giving the induction phase and going ahead with the transplant, even with the regular induction, as you can very well see with whatever data is there in front of you. There is no data apart from this. That I think there is one data more after that which has come up from Max Delhi, which also they have shown good outcomes. So we should not be worried much about the reactivation and all. Unless until the patient has a really bad MDR tuberculosis, then that's a different situation altogether.
And are you comfortable using rifampicin as a ATT after transplantation, or you try to make some modifications to alternative agents?
So that's a very important question, because all these data what I showed you of 70 odd patient that was shown were on non-rifampicin based regime. Many people do use rifampicin, but that can get messy because we had a lot of discussion about tacrolimus level. We are not sure about that itself. And then you use this, and then it leads to havoc with tacrolimus level. So we, except for one or two cases in the post-transplant period, when the patient had the brain abscess secondary to tuberculosis, that one case I remember. Apart from that, we have been very successful without using rifampicin. Rifabutin you can, but it becomes difficult to procure it many times. Yeah.
My next question is for Dr. Pankaj. UTI is a vexing problem that we face pre-transplant as well as post-transplantation. So we come across many patients who have had history of urinary tract infection, mainly diabetics, elderly female patients, postmenopausal female patients. And this patient is now has CKD and has been planned for transplantation. So what is your thought or take on reducing what strategies for reducing post-transplant UTIs? Again, we don't have any firm guidelines on that, but what is your take on that?
Yeah, I think the first and foremost, pre-transplant only, if the etiology is like reflux or some polycystic kidney disease that are like prone for recurrent UTI post-transplant. So probably you need to sort that, like also the neurogenic bladders or some bladder neck issues. So that need to be tackled before going for the transplant so that you can avoid the recurrent UTIs. I think about the post-transplant, I think not putting a DJ stent, there is fairly decent amount of data, like when they compare between the incidence of UTI in a patient with DJ stent and without. So I think if possible, like if urologist agrees, not putting DJ stent, or if putting, removing it maybe at 2 or 3 week, probably help to prevent. I think second is giving prophylactic immunosuppression, like antibiotic, like we give Septran for PCP, and that will help for the prevention of UTI also. So that can be like again guideline not clear for till 1 year or lifelong. So maybe in patient you can like with recurrent UTI can continue lifelong of Septran. I think again, third point should be like about asymptomatic bacteriuria. Like again, it is a gray area whether it is need to be treated or not treated. So I think patient with a like recurrent UTI, then history of recurrent UTI pre-transplant, at least for the initial 3 or 4 months, you should monitor asymptomatic bacteriuria and probably treat it. Like again, no good data, but I think that is a group of recurrent UTI where asymptomatic bacteriuria can be treated. And I think apart from that, the regular behavioral changes like frequent voiding and hygiene and all that stuff.
If we have any questions from the audience, we can take that. Gupta sir.
Excellent presentation, Pranav. Just few suggestions. In one of your slides, the level of evidence you mentioned was 2C. It's a weak evidence, sir. We can't turn it into the practice. That evidence is not enough to change your practice. Second thing I like to quote is like when you are quoting a retrospective data, that is also a weak evidence. See, after a randomized controlled trial, you have a cohort which goes forward. It's a prospective data rather than retrospective. The retrospective data is plucked with lot many biases. And if you want to adopt that evidence to change your practice, I think it's not fair. Either you wait for more studies to come, do a meta-analysis or systemic reviews of all studies that have been published so far, or wait for if randomized controlled large critically appraised trial is possible, then that becomes a gold standard to change your practice based on the evidence. So otherwise, there is something like a dynamics of evidence coming up. It comes up, are negated by few negative trials, and people don't accept it. The real gold standard of evidence is it should be accepted by treating clinicians for patients. It should remain intact over a period of time, and that is called as test of time. So before you embark on changing your practice, be careful to judge the evidence. That is very important because you may prove wrong down the period of time that that evidence was really weak and that has fizzled out. Thank you very much.
Thank you, sir. That point is very well taken, actually. What you rightly said, and that's what was my disclaimer before I started this talk. You don't have evidence. I'm really sorry, but you don't have evidence. You look at the KDU guidelines, all the evidence which pertain to the infectious thing is either to see worse. But whatever data we have is this. We definitely need to generate more data. And once again, the onus comes on us from India to generate these data pertaining to these infections, which is more common with us rather than outside, which will need a multi-center. Yeah, definitely it should not change your practice completely, but yeah.
Exercise and have a fair conclusion rather than extrapolating something which has occurred in the United States or another country.
Right.
So that demographically can be reproduced in our society.
Exactly, sir. Exactly.
So I'm really worried about change in practice.
Yes.
There was some discussion on change in practice. Have you changed your practice of putting on completely before transplant methodologies or continue with teaching for years? Very important question. There are wiser paid people here in the sense that we can do that rather than depending on the people.
Right.
Any more comments from the panelists if you do have?
Yeah, I think we need certain discussion on the disease donor with infections when they are being considered for transplant.
As
So
a recipient, should we be?
no, this is in view of the recipient. So we do not call it marginal, but if the disease donor is HBS positive, detected with hepatitis B, and the recipient is normal, there is no waiting list of hepatitis B positive patient. In such scenario, the risk of transmission and the history of vaccination of recipient and the inability to have the immediate anti-HS antibody titer. So in such scenarios, how we can proceed? Similarly, for other infections. So just I wanted to highlight, yesterday we had a discussion with a colleague from India only, and what they had seen, the during disease donor workup, the patient's viral markers were negative. But when the liver and two kidneys were transplanted in the recipients, in a week, all the three turned out to be HIV positive. So this is a very important area, the methodology adopted during the donation. So only the card testing, not the alpha method, CLIA method. So we have to make sure when we are going ahead with the disease donor program, that which method was adopted and how much sensitive the method was, because now it's a medical legal issue. Recently, I went through an article where the rabies was uh, transmitted through the disease donation into the recipients, and the only corneas were salvaged. The other recipients who were transplanted the cornea are doing fine. Rest liver and two kidneys, they succumb to the rabies also. So this is very difficult area of transplant and infection. We have to individualize and be cautious with it.
That's a point well taken. Any more questions from the audience? If there are no more questions, we can close the session.
Amit,
Samir sir.
one small point on our personal experience is in patients of recurrent UTI. Since many years, we've been using long-term urinary alkalinization, and that has given us substantially good results. Any experience in that? Urinary alkalizer? They have been using for, I don't know, many years. Salgia, sir?
Local estrogen cream in postmenopausal women also give good results, not specifically tested in the post-transplant period, but as such in postmenopausal females, the results have been good.
I just have want to take opinion of the house regarding uh, in a recipient with prior history of tuberculosis and he's undergoing for the transplant. Do you use prophylactic AKT isoniazid for 6 months or 9 months, or if there is no evidence prior to the evaluation of activation, you don't do anything like?
I use isoniazid or moxiflox minimum 1 year post transplant. 1 year minimum. But the practice differs. It depends on the practice pattern of individual colleagues. Jay sir.
Don't want to waste it when patient develops active tuberculosis, because you create resistance against that, and it is such a wonderful drug, you do not to waste it. Once the patient develops active tuberculosis, just treat it with 4 drugs. Otherwise, don't use prophylaxis because it is not going to serve the purpose.
The incidence of latent tuberculosis itself is around 40% to 50% in India. So if you end up by that criteria giving it, you have to treat 40-50% of these patients who don't have history of tuberculosis.
All right. Thank you all the panelists for excellent discussion.
Thank you, Amit sir. I'll request Dr. VL Gupta sir to felicitate our speaker for the session, Dr. Pranav Kumar Jha. Today we are fortunate to have Dr. Samir Chaube amongst us. He is the past president of our society. I request Dr. VL Gupta sir to felicitate Dr. Samir Chaube sir. Dr. Manish Balwani sir. Dr. Kapil Sejpal, Dr. Pankaj Javandia, I request Dr. VL Gupta sir to felicitate our moderator for today's session, Dr. Amit Pasari sir. I think we'll all agree that today we have had a phenomenal discussion about renal transplantation, merits and demerits. I'll request our Honorable Secretary, Dr. Utkarsh Deshmukh, to propose the formal vote of thanks.
Good afternoon, all. I am the last person between lunch and you. I will not take lots of much time. I would like to first say thanks to Dr. Salgia sir and Dr. Jay Kripani sir. Just 3 weeks back we met in Bhopal and he agreed to the short notice and came here. The lecture given by Kaldiga sir was very wonderful and it was really enlightening to us. I would like to thanks to Dr. Sueshri madam for moderating the session and none other and our moderator for all the things and Dr. VL Gupta sir, Kripani sir, Dr. Manoj Dhanakar and of course Monali madam ma'am. Uh, in spite of the busy schedule, Dr. M. Bahadur came from Mumbai and delivered a very phenomenal lecture here. I listened to him almost a decade back and then again attended his lecture. Dr. Khandekar sir, who has done very good moderation for that topic, and of course the panelists Dr. Piyush Kumatkar, Dr. Jitesh Jeshwani, Dr. Vishal Ram, Dr. Amal Bhavani, who has participated well and organized the thing. And last but not the least, our Dr. Pranav Jha sir, who has uh, done the things in the death overs. He was taking the wickets and also hitting the sixes. Really nice lecture with his all question answer pattern and enlightened the things very well. I would like to thank Dr. Amit Pasari sir for his moderation. All the panelists, Dr. Samir Chobe sir, Dr. Manish Balwani, Dr. Pawan Javandia and Kapil Sejbal. I would like to thank all the participants for coming, their busy schedule and definitely the traffic which hurdled all of us. Thanks for making this session very fruitful and enlighten all of us here. I would like to thank all the transplant coordinator, my OT staff who has come here and attended the lecture. That is really good for us and inspiring to us, definitely. I would like to thank each and everyone. And also, I would like to thank our event manager, Mr. Andulkar and his team for coordinating the session. And also, he has given the importance to and accept our panel in spite of the Modi ji is coming here. Thank you, all of you. Sir, we will raise up here for the national anthem and followed by the photograph. Thank you all.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा तमिल उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जगति तरंगा तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Bharat Mata ki Jai. So I would request all of you for the group photograph. Thank you.